routine OCT exam and the eye injection for her right eye. I typically alternate eyes. I don't typically do bilateral injections. And we did her Eylea injection. Everything went well and smoothly. But she called our office 3 days later, and she said she has a dramatic decrease in her vision, and she's been complaining of this mild aching pain since the morning. So we immediately told her to come in. And this was her presentation, which came into the office. So her visual acuity had dropped down from 20/40 to about counting fingers in 1 foot. And she has this red, angry eye. You can see some corneal edema, haziness due to quite a bit of flare and 4+ cell in the AC. And you can see a hypopyon developing. So this is kind of a classic presentation, kind of a nightmare scenario with a patient that's been doing really well and has a nice management plan, and then comes in with this complication. So diagnosis is usually at this stage is not too hard to make. It's the management that is kind of tricky. So when we think about diagnosis, number one and that comes up to mind is bacterial endophthalmitis. So endophthalmitis, just to touch base, is classified different methods. We're all aware that endophthalmitis just means inflammation in the internal structure of the eye, the aqueous humor and the vitreous, and different classification systems as far as sterile versus infectious. And when we talk about infectious, we're talking either endogenous, which means that it's a seeding from another source of infection somewhere else in the body, versus exogenous, introduced organism into the eye via either trauma or via surgical, which is another form of trauma, through a surgical procedure. And then it can be classified by infectious organism. The most common, of course, with exogenous is bacterial. The other forms could be fungal, parasitic, or viral. With endogenous, there's a lot of literature that says fungal might be the most common organism. And then another form of classification of endophthalmitis is by latency of symptoms. The acute, which is the first week to 2 weeks after the inciting incident, versus delayed diagnosis. Other terms are either latent endophthalmitis or indolent endophthalmitis. And the classic one is Propionibacterium acnes. Endophthalmitis is rare, but we do so many procedures that it's not as rare as we would like it to be. Almost everybody has been exposed to endophthalmitis in their practice. This is a survey of different series of injections that were published in the literature, going back to 2008 when the boom of intraocular injections first started. And you can see that even though some series had 0 cases of endophthalmitis, extremely rare. And the post-intravitreal injection, on average, is an incidence of 1 in 3,000 to 1 in 5,000. The original, the Lucentis and the studies said a rate of about 1 in 17,000, but in real practice, it's much more common. Analysis of CMS, which is the reimbursement data, which shows that in the real life, people, when they bill for procedures, it's about 1 in 1,000. So there are some people saying that in actual practice, not published practice, but in actual practice in the United States, there might be 1 in 1,000 might be the rate of endophthalmitis post-injections. Post-cataract, the classic is 1 in 1,000, but with current prophylaxis, the rate has been substantially lowered, and people are talking about 1 in 2,000 or even less. So, as I said, the diagnosis is really no mystery. We know what we're dealing with typically when we see it on the hoof when it comes to the practice. Management is what it's all about. And with endophthalmitis, I gotta emphasize again and again and again and again that prophylaxis, prevention is the key. You really need to try to prevent rather than having to deal with the sequel of getting endophthalmitis. The less incidence, the less often a patient gets it, the more eyes you're going to be able to save. Because once a patient has had endophthalmitis, time is of the essence. You can manage perfectly well and still get a poor outcome if you have a pretty virulent organism or a bad infection. So we're going to be talking about different aspects of prevention that's been addressed in the literature that we're aware of. And the first thing I'm going to talk about is betadine. And betadine, if I could say take-home message from my talk to anybody, when you think about endophthalmitis and endophthalmitis prevention, the number one thing you have to think about is betadine, because betadine has been conclusively proven again and again to be the number one go-to method to prevent endophthalmitis. We use 5% betadine or povidone iodine, and it can either be instilled as an eye drop before and after the procedure, or it can be done as a flush. And some people advocate it both ways. If you put in enough amount in an eye drop, I personally do not flush the eye with the povidone iodine itself. Timing of application is critical. Sometimes you put the drop in, the patient closes their eye, you walk around, you come back, you do some anesthesia, and then you do the injection. Well, it's been proven that the last thing that needs to go on that surface of the eye is the betadine before you do the injection itself. And you try to prevent that eyelid from coming down and closing and touching the eye surface before you do the injection. So the eyelid is retracted either by speculum or by fingers. Betadine is put in. About 5 to 10 seconds later, as a minimum, the injection happens. There are, of course, people that say they have betadine allergy or iodine allergy. I've had many people come in and say they're allergic to iodine or betadine. I've still used iodine or betadine, and there has been no problems or no reactions. I do think that it's way over-reported than being actually in clinically, but there's also in the literature about using aqueous chlorhexidine, not the actual chlorhexidine, which is toxic, but an aqueous form of it that can also be preventative and prophylactic for getting endophthalmitis. Use of a speculum, I typically use a speculum in all my injections. It has traditionally been advocated for use, but there's been some literature series in which has been said that if you have a good assistance and people can help you keep that eyelid open after you put in the betadine and before you do the injection, then you get the same results. And that makes sense. It doesn't matter using speculum as much as keeping those eyelids away from the conjunctival surface. Office versus operating room. In the USA, we mainly use the office. I know in the Middle East that they often will use the operating room. Maybe Muhammad, Dr. Muhammad Al-Wahab, what are you guys doing these days?
Minor OT, Amjad. We are doing in a minor OT, not in a major OT.
That's what I thought. We usually do it in our lanes, and we've had really good outcomes with it. There's been a couple of literature publications that have showed there's really no difference in endophthalmitis from the OR versus the office, and basically use what you're comfortable with. And when we first started doing these injections, almost everybody used to get antibiotic eye drops, maybe for a day or two before the injection, but definitely 3 days after the injection. And now we've gone away with that. For the last 4 or 5 years, I have not put any patient on preventative or prophylactic antibiotic drops for injections. However, the literature is strongly for using prophylactic intracameral antibiotics in cataract surgery. It has been shown to be effective. And most people use either cefuroxime or moxifloxacin in the bag. Use of mask or sterile gloves. Of course, if you're in a minor OR and operating room, you will be using them. In the office, we've gone away from that. I used masks for a while until the literature showed that just avoiding speaking is just as good. And so that's what we do. We tell the patient we're not going to be talking to them, and we ask them not to talk while the eyelid is being held open after the betadine is put in and before we do the injection. And we have the same results, very low rates of endophthalmitis. And we don't use sterile gloves. We do glove, but we do not use sterile gloves, and we have not had a problem with that. So there are other issues with prophylaxis, and type of anesthesia has not been proven to increase the endophthalmitis rates. You can use subconjunctival injection or topical drops or gel. But in gel, be aware that if you put a gel to numb up the eye, you can't use the gel and then put a betadine afterwards, because this gel will prevent the betadine from touching the conjunctival surface. So the one exception to the rule is using betadine before the gel, or wash out the gel and then use the betadine. Different techniques for prevention of vitreous prolapse have not shown a decreased rate of endophthalmitis. Scrubbing eyelids and eyelashes with antiseptic solution, again, has not made any difference. And the site of injection, any of the quadrants around the eye, doesn't really alter the endophthalmitis rates. Some practices here in the United States do bilateral same-day injections because of the high volume they have. We don't do that routinely in my practice, but it's been proven to not increase the rate of endophthalmitis, but you have to make sure that you use a different set of instruments and re-glove, and do everything as if this patient was coming in for a second visit before doing the injection in the other eye. So we're going to medical management. So now, if prevention, you've done all of this, and you've cut down the rate of endophthalmitis as much as you can, and you still get maybe that 1 in 5,000, 1 in 8,000 case of endophthalmitis, how do you treat it medically? And most of our patients we treat medically in our office. The seminal trial, the seminal investigation is the endophthalmitis vitrectomy study that came out in 1995, and we're all aware of it. And what that endophthalmitis vitrectomy study pointed out is there's no benefit for systemic antibiotics in endophthalmitis, exogenous endophthalmitis. Immediate vitrectomy is of extra benefit, only light perception, vision, or worse. And the vitreous stab and injection done in the office with ceftazidime and amikacin, was the antibiotics they used, was just as effective for hand motion, vision, and better. Now, this study was done in 1995. The main caveat is they only studied post-cataract surgery in endophthalmitis. And this was when surgery was done large gauge. We didn't have small gauge, the perfected techniques that we have these days for vitreoretinal surgery. And we have improved the antibiotics we have available. Both systemic antibiotics and injectables have improved tremendously in efficacy and bioavailability. And my colleague who's going to follow me in presentation is going to talk about the surgical aspects of taking care of the endophthalmitis. So back to our case presentation, this patient that walked to my practice one day after getting the Eylea injection with kind of fingers of 1 foot. If we apply the endophthalmitis vitrectomy study criteria to her, then we're going to go ahead and do the tap and inject, which is what was performed in my office. And a quick couple of words about the technique I use. I do a tap with a 3 cc syringe, which is you're done with a 25 gauge needle in the pars plana. I usually do subconj anesthesia, but if the patient is very sensitive and is very inflamed, sometimes we do retrobulbar anesthesia in the office. We aspirate 0.2 cc. Sometimes we get a dry tap and it's really tough to get fluid and you have to reposition the tip of the needle, back up a little bit with it, or move it into a different spot in the vitreous cavity. Very gently aspirate. You don't want to create a lot of traction on the vitreous and, God forbid, create a retinal tear or detachment. If after 2 or 3 attempts you still have a dry tap, then what we do is we do an AC tap with a tuberculin syringe with a 27 gauge needle. And I usually have an assistant help me to aspirate the fluid from the AC. Don't go after the hypokian material, go after the fluid. And of course, you cap the sample, label it, send to the lab. We suspect bacterial, we do a gram stain and culture sensitivity, but that AC fluid or vitreous fluid can be used to do specific cultures for a fungal or PCR test if you think this might be a part of the differential diagnosis. Nowadays, I inject vanco and ceftazidime with these with that concentrations. I do not typically inject dexamethasone. In penicillin allergies, I substitute amikacin for ceftazidime. And I always put them on oral moxifloxacin, which has been proven to have good penetrance into the vitreous cavity and crosses the blood-retinal barrier. I give them 400 milligrams PO once daily for 10 days. And I will put them on topical moxifloxacin, Vigamox, and Durezol, difluprednate, eye drops, QID. And if the eye is very inflamed, then I can go up with Durezol every 2 hours. That's my steroid of choice, is topical, not injectable. And then I follow them every day for the next few days. I will ask them about pain. We do the clinical exam for inflammatory signs, and we do serial ultrasound B-scan to look at the retina and inflammation in the vitreous. If there is no significant improvement in any of the above in the next 48 to 72 hours, then we go ahead with surgical options and we consider doing a vitrectomy. So back to this patient, our culture was staph epi, and thankfully sensitive to vancomycin. And we followed her up daily. Pain resolved over 48 hours. The hypopian fibrosed, and the inflammation in the AC resolved over the next week or so. And her visual acuity over a month gradually improved back to 20/70. Unfortunately, it didn't get any better because she had diabetic retinopathy, she had an inflamed eye, she got much worse macular edema, and we had to resume her anti-VEGF and went back on that, and she's doing better today. Thank you very much.
Thank you very much, Amjad, for this excellent presentation. If there is any question from dear here panelists, Dr. Hasan, Dr. Ramzi, you can unmute yourself, please all. Dr. Ahmed Al-Barqi, you are here also. Dr. Iman. Anyone want to ask Dr. Amjad about his presentation?
Dr. Hamad, it's very nice, very good call. So I would like to ask, after the first injection, if there is no progression, there is no improvement, what's your behavior? Do you do it in second injection and when, or prefer vitrectomy?
So
Do you believe, do you believe that the second injection, if the first injection is not improve the clinical situation, believe that second injections help, or do directly vitrectomy?
So you typically by the time 2 or 3 days have passed, you have the results of the gram stain and hopefully a little preliminary result of the culture. And depending on that, if it's something that I think is not sensitive to our medication, but sensitive to a different antibiotic, then I will do a secondary injection in the office with the antibiotic it's sensitive to. But if I don't have any useful data from the gram stain culture sensitivity, and the patient is not responding to my tap and inject, then I would say 80 or 90% of the time, after 2 or 3 days, I would go to vitrectomy these days. Yeah. I will not do a second tap and inject.
Good.
Any other questions, Ahmed? Hasan? Yes, Ahmed.
No, yeah, just a quick comment, because Dr. Amjad, very nice case, and he mentioned about the EVS, the endophthalmitis vitrectomy study, and as you mentioned in your talk that the situation now, or the life now changed after the new small gauge vitrectomy, and also the antibiotic, systemic antibiotic now has good penetration. So my question is, do you think, because for me, I really don't follow now exactly the EVS, because I think early vitrectomy will help, because as you mentioned that you take a sample with the 25 gauge needle with a syringe, and all know that in endophthalmitis, the tissue fragile, and while you're aspirating this, you might create a tear somewhere if the retina is fragile. So I think the best way is to do the tab using now the new 27 gauge vitrectomy. You take it without any traction. You get a lot of big volume if the vitreous is not it's dry a little, so you will suffer to get a big sample. So for myself, I think if the patient has counting finger and poor red reflex, personally, I will take direct to the OR and take the sample with the, if I have the time and they have the availability, for sure I will use the 27 gauge vitrectomy probe better than this. And for sure we can discuss later about, I need also to know the insight from you all about the EVS. Are you still following it exactly, or you change your practice nowadays?
Well, as I said, the EVS has been modified quite a bit. I mean, the EVS had no systemic antibiotics, but I use moxifloxacin. So that's the deviation from the EVS. I still use the criteria for counting hand motion vision above and below, because if I get somebody that's not hand motions, light perception, definitely a vitrectomy immediately. I still use that criteria. But my partners and I, we're 3 retina specialists in my practice. We do close to 8,000 to 10,000 injections a year. We get 1 to 2 endophthalmitis every single year, despite everything. This is what we treat with, and I would say 90% of our patients, 90% do very well with tap and inject without going to the OR. The problem with the OR here in the United States is, even though I own a surgical center, the surgical center is being used. Somebody's doing cataract surgery. Yeah. I pick up the phone and call them. Yeah. It's going to be an hour or 2 before the patient.
Available all the time. Yes, yes.
They're in my office. I can do a tap and inject in 5 minutes. Yeah. So that's why I still do the tap and inject, because it works most of the time. Most of the time, I don't need to go to the operating room. But if they don't respond to the tap and inject, I am very quick to pull the trigger on a vitrectomy. And I think a vitrectomy is playing more and more a role in management of the tougher endophthalmitis cases. Absolutely.
I personally have also, even patient with light perception, I tend to go ahead for intravitreal tap and injection before going to the operation room. I think that even that time period of 24 hours, maybe schedule it for tomorrow if you don't have a time today. I think it makes a huge difference intraoperatively. Dealing with the membrane is not so mucousy like. It's more fibrous, so it's easier to remove. And even intraoperatively, the gel, the vitreous, is much easier to vitrectomize. And I think you go a long way starting with intravitreal tap and injection before going to vitrectomy.
Makes sense.
I completely
Dr.
agree
Ramzi,
with
yes,
Dr.
please.
Hasan. Yeah, I completely agree with Dr. Hasan about even if we plan to do vitrectomy immediately, but it's not possible to do immediately vitrectomy. Therefore, tap and injections is immediately after diagnosis is very important. Even if we plan to do vitrectomy in the same day, so it takes several hours to get available operating room, the other things. So I completely agree that to do tap and injection is as early as possible after diagnosis. That's very important. So I think we all agree about that schedule, procedure.
You know, there's just a new thing came up at the European European Retina Society that tap and inject results just similar to vitrectomy, and this is just recently published online. I can share that with you. And I don't know. This is just it's not a it's a literature going backward. So it's a retrospective review. So
a meta-analysis, right?
Meta-analysis, yeah, a retrospective review, endophthalmitis vitrectomy in Europe, European Society, talking about how intravitreal tap injects, you know, does just as well with vitrectomy.
No, as I said, it's our go-to method of taking care of our patients initially. We get excellent results with it 90% of the time. We don't need to do a repeat injection, or we don't need to do a vitrectomy, but obviously there are patients that are going to need to be more aggressive with, and you need to proceed with other so on. But I do believe a vitreous tap and injection is so quick, it's so fast, it's done in the office. We have, even though, like I said, we see people maybe twice a year, we always have in the fridge in our office, we always have this antibiotics ready. They have a 2-month expiry date. So every 2 months they're thrown out, and we order another antibiotics, and they're kept in the fridge even if we don't use them. And we keep 2 sets of them just in case. You know, we never had 2 endophthalmitis arrive the same day, but you gotta be ready for that. And I think it's such an easy thing, and you should be prepared for it.
Thank you very much for this excellent presentation, Amjad, and very useful, interactive between the panelists. We have only one question before we move to Dr. Ramzi. In an angry eye with corneal abscess, cannot tell if vitreous is affected except increase echo via ultrasound. Would you go for intravitreal antibiotic, because sometimes we cannot tell if it is only cornea or AC or vitritis? Okay, I'm just.
So if somebody comes in with a corneal ulcer, they can be a very angry corneal ulcer. They can have a pretty bad anterior chamber reaction, and it can look very similar to the picture I showed you with the hypopion. And then it becomes a difficult diagnostic issue. I will do the ultrasound. If the ultrasound does show vitreous, a significant vitritis or inflammation of the vitreous, I do tend towards the tap and inject. I think the ultrasound is my tip off to that, because I would say if it's a corneal ulcer, I would expect and I would think that most of the inflammation would stay in the anterior chamber. If the patient has not had a recent cataract surgery, then there should be a nice barrier from the lens, the PCIOL or the natural lens, to prevent that inflammation from really going back to the vitreous. And if I see vitritis, significant vitritis, I err on the side of treating as if it's an endophthalmitis and do the tap and inject. But I would also, of course, cover the corneal ulcer and treat the corneal ulcer aggressively also. And I would recommend the corneal consultations. I'm not a cornea specialist. I'll make sure the cornea get involved with that case.
Thank you very much. Now it's my pleasure to introduce Dr. Ramzi Absi. He is an MD professor, consultant ophthalmic surgeon, head and founder of Retina Eye Hospital, Bursa, Turkey. Thank you, Dr. Ramzi, for being with us, and the mic with you. Thank you.
Thank you. So, thank you, Dr. Mohammed. So, before my talk, I would like to thank Dr. Mohammed for his kind invitation. This is my second duty in his webinar, and I'm really appreciate to be here and to be a member of this webinar and share my experience with you. So in my talk, I will speak about the surgical side of endophthalmitis with case presentation. I have no financial disclosure. The first case has a medical history, 78 years old woman, presented to us with complaints of progressive visual loss in the right eye for the past 4 weeks. And she had undergone uncomplicated cataract surgery from the same eye 6 weeks ago. And this is complaining start 2 weeks after the surgery, and progressive vision loss, progressive versions of the clinical pictures. So in the ocular examination, the vision was counting finger and intraocular pressure was normal, but anterior segment, there was 3 positive cell reaction, but no fibrin reaction and no hypopyon, and details of the anterior segment was distinguished. And what about the posterior segment? There was severe vitreous condensation. Details were not distinguishable. As you see here, this picture was taken during surgery. There was white opaque condensation, also small round ball-like condensation in vitreous cavity. So this is a delay with endophthalmitis. It's not acute endophthalmitis. And when we observe this was also visible during the biomicroscopic examination. I suspect about fungal endophthalmitis or a kind of low-grade endophthalmitis, and therefore, in this patient, we plan to do a vitrectomy because of the severe condensation. A day after this visit, we plan the surgery, and when we go into the with surgery to the vitreous cavity, we observe a very typical finding of fungal endophthalmitis after co-vitrectomy. As you see, has really a severe condensation. We observe many small fluffy balls overlying the retina. This is really typical for fungal endophthalmitis. The patient has no systemic problem. Then we, in such case, I have really not huge experience with fungal endophthalmitis, but I plan to clean all balls, all condensations, to reduce the spore load in the vitreous cavity and to get to be able to treat patients easily. And then with giving time and clean all the balls, not on the posterior pole, also on the periphery. And also I prefer to do complete vitrectomy and clean all the vitreous space. So in such patient, I think this is important to reduce the spores load in the vitreous cavity. So with indentation, also complete vitreous-based cleaning we perform, but the retina was not any toxic effect on the retina. Macular area was fine. And then we apply fluid air exchange 2 times to clean the rest of condensations and clean vitreous completely. And then during this surgery, we send the samples to the laboratory to make us wet mount looking. And this is the end of the surgery. And the culture was negative after surgery in this patient, but wet mount preparation, and they observed candida spores, and we applied intravitreal amphotericin injections, and also we gave systemic fluconazole treatment in this patient. And this picture was 4 weeks after surgery. As you see, retina is completely recovered and there is no recurrence, and the patient did not need second intravitreal injection. The systemic treatment we gave 2 weeks for 2 weeks fluconazole treatment. Also topical steroids we apply these patients. Also topical antibiotics for the secondary infections. This is the OCT pictures, and the patient vision improved to 20/20 after this surgery. And I follow this patient almost more than 3 years. There is no recurrence, and still the patient has saved the same vision. So in summary, for fungal endophthalmitis, the diagnosis of fungal endophthalmitis is based on eye findings rather than vitreous culture. And spores can be seen by wet mount preparation of vitreous samples. And systemic treatment is necessary in fungal endophthalmitis as opposed to bacterial endophthalmitis. In usually bacterial endophthalmitis, I do not use systemic treatment. Dr. Hamad mentioned about the systemic moxifloxacin treatment is another option, but usually I prefer intravitreal injection and topical treatments. But in fungal endophthalmitis, this is important. We should give systemic treatment, or even almost also in most of the fungal endophthalmitis. If there is only choroidititis, if there is no vitreous condensation, it's not like a choroidititis, not the typical endophthalmitis. We may treat this patient with only systemic treatment also. So complete vitrectomy and patient clinic, all opacities is important to reduce spores load in the vitreous cavity and to get successful results. So this is my way to treat fungal endophthalmitis. But as I told you before, I have not many experience. I have a few cases. One of them is this case, and I apply this surgery. Then if 2 or 3 cases more, and also we get good results. So maybe the second case is with bacterial endophthalmitis, Mohammed. If you want, we can discuss this fungal endophthalmitis with our colleagues and also continue the second surgery.
Yeah, if we can have any question from dear here colleagues Hasan or Amjad or Dr. Ahmed, Dr. Iman, anyone to ask Dr. Ramzi about the case? Or have any question to Dr. Ramzi?
I usually
comment
of and am conservative regarding doing shaving for any endophthalmitis cases, just in case I end up, you know, having a tear or a hole or something, because that kind of makes it a different animal when you have an endophthalmitis and retinal detachment. And it'd be really nice not to need to use a tamponade or like a gas or silicone oil. So I kind of tend not to shave if possible. And I mean, in some instances where they're really severe trocar incarceration or cannula incarceration, then I would probably do it. But I'm more kind of do a conservative vitrectomy and then just put my antibiotics and that's all.
You mean Hasan, you don't remove all the opacities as Dr. Ramzi, if in case we are now talking, I mean, specifically about the candida infection. I mean,
yeah, I'm talking about the peripheral vitreous. Vitreous-based shaving. That's my approach usually.
But if we speak about the bacterial endophthalmitis, is virulent bacterial endophthalmitis, I agree with you to not to do complete vitrectomy. Even sometimes I don't remove the posterior hyaloid. It's very fragile retina, very ischemic, and it's toxic effect on the retina. But if we speak about the fungal endophthalmitis, so this is different way. So in fungal endophthalmitis, if there is no retinal defect, if there is no retinal toxic effect on the retina, if there is no retinitis, choroidititis, I pay attention to remove all the vitreous as much as possible. For the fungal endophthalmitis is different behavior and comparing the bacterial endophthalmitis.
Good point.
Amjad, if you have any comments, please.
Are you talking to me, Muhammad?
Yeah, if you have any comment or
I think it's a beautiful case. I applaud Dr. Ramzi. I think he did a really nice job with it. Those are really hard cases. I mean, they really are hard cases. And I agree with Dr. Hasan that you want to do a minimal touch usually with endophthalmitis. You really try to be very minimal touch with those. But if you have a really bad fungal, then you got to try to remove as much as possible. We've had cases where we've done this in combination with anterior segment people, where we've gone up all and then to anterior the far periphery and go up to all the way up to ciliary body and actually shave around the ciliary body because there's thick adhesions up there, almost like very thick anterior PDR. They can sometimes have anterior loops, and you have to try to get rid of those sometimes just to get rid of the fungal spores, get rid of the fungal material. And I remember one case in which it was a fungal endophthalmitis from a corneal ulcer, a fungal corneal ulcer. And the part about that is the cornea had to be removed. We had to put a keratoprosthesis and work under a keratoprosthesis to try to take the fungal material that had crawled from the cornea back, cover the ciliary body, and go into the retina and vitreous cavity. And that was a really messy case. That took a few hours. So this is not easy, but Dr. Ramzi, I think you did a fantastic job with that one.
I have two questions, Dr. Ramzi, for you. This is from a participant. Should we, okay, who answer this? Should we start with intravitreal antifungal before vitrectomy, or the moment there was vitritis, then surgery is the answer? I mean, what is the criteria to go for? If we can ask in this question, what is the criteria that tell you to go for surgical intervention rather than treat as medically for fungal infection?
So in fungal endophthalmitis, it's not like bacterial virulent endophthalmitis. It's like low grade and delayed endophthalmitis. And also my few experience with the patients, and I really try to completely clean the vitreous space, vitreous condensations. And I believe that if we do not do this, and we can do injection maybe, but injection, antifungal injection in the vitreous cavity with condensed vitreous is not really helps. And therefore, we should remove all the vitreous, all the condensation, and do the injection at the same period. So usually I prefer to do vitrectomy and clean all the vitreous and then give injection. Do not wait, antifungal injection, wait a few days, just go directly vitrectomy.
Anyway, this question also is answered by my brother, Dr. Hasan. Sorry that I didn't notice that, Hasan. You already answered the question by sending an answer. Anyway, we can have the second case. We have many questions for Dr. Amjad and Dr. Ramzi. Maybe after we finish the second case, then we have all other balanced questions. Is that okay? Okay, can we go Dr. Hasan, Dr. Ramzi now for the second case?
So this is another patient with 88 years old man referred to us with complaint of severe pain, visual loss, and redness in the right eye after for 6 days. And she had uncomplicated cataract surgery from the same eye 3 weeks ago, and the complaint starts almost a week after, 2 weeks after surgery. And ocular examination, the vascular visually active was 120, and anterior segment has hemorrhage, fibrin reaction, also hypopyon. And we applied vitreous tap and intravitreal injection same day immediately after diagnosis, and follow the patients. And during the 4 days, we observed the improvement of the patients, but not the visual improvement, only the hypopyon and the fibrin reaction regress, but there are still severe vitreous condensation, and therefore I plan to do vitrectomy this patient. And this is the surgery. As you see again, there was really condensation. So we applied delay vitrectomy after injection if the vitreous has really severe condensation, like in these patients, because in such patient it's not really see the cleaning of the vitreous it takes for a long period of time to completely clean, and therefore even we get positive answer for the injection. In this massive case, I prefer vitrectomy. So after vitrectomy also there was some fluffy materials overlying the retina, but in this patient I did not clean complete the vitreous base, but again this was not really attached hyaloid. There is no retinal toxicity, and therefore I do core vitrectomy as much as possible and clean the vitreous, but not complete cleaning of the vitreous space. So in such patient, I prefer, just after surgery, I prefer to do a 360-degree laser around the periphery to prevent potential retinal tear and retinal detachment complication. So as you see, this is the picture. So these both cases of my patient is not really massive case. There is no bacterial and toxicity on the retina, and apply the laser. Some did not give any tamponate materials. So clean also vitreous, anterior segment of the patient. So the microbiological results and gram-positive coagulase negative staph epi was the in our patients. So in summary, vitreous staph and intravitreal antibiotics injection should be initiated immediately after the clinical diagnosis of bacterial.
Hello, Dr. Ramzi. We can't hear you. Hasan, Amjad, are you hearing Dr. Ramzi?
Yeah. No, we can't hear Dr. Ramzi. I think
there is some interruption in his
I think he
internet.
lost him, yeah, internet issues, yes. He's now here again.
Oh, there he is.
Is it okay?
Yeah, we can see you now, Dr. Ramzi.
Can we go back or you just stop here?
No, because already we lost you for 2 minutes.
Okay.
We didn't listen to you. You can give us only the after the videos. Just start from the videos, the result and the.
Yeah, the macrobiological result staph epi was in our culture. Yes, coagulase negative bacteria, and so in this patient also we did not give another injection. And just topical treatment, steroids and antibiotic treatments after surgery, and we obtain complete recovery. So in summary, in bacterial endophthalmitis, vitreous staph and intravitreal antibiotic injection should be initiated immediately after the clinical diagnosis of bacterial endophthalmitis, even if we plan the vitrectomy, as we discussed before, because vitrectomy takes, vitrectomy takes several times in the busy day, and operating room is not available, and therefore I do injection as immediately after diagnosis. And if there is no improvement with 48 hours after the injection in culture negative patients, I prefer to do vitrectomy instead of to do second injection in this patient, as also we discussed this together with in the previous talks. And also, even if there is a clinical improvement, vitrectomy can be performed to clear vitreous opacities later as a delayed vitrectomies. So this is end of my second case. We can discuss also if you.
Thank you very much, Dr. Ramzi. An excellent presentation, excellent cases, excellent management also. We learn also a lot. So there is a lot of debate. I know there is many different ways for dealing, but already we talked about several points that we discussed. We will answer several questions unless there is, before that, if there is any comment from any one of the panelists, Dr. Hasan, Amjad, Ahmed, and Dr. Iman. If there is any comment, Dr. Ahmed, please, if you want to go ahead.
Yeah, just to go with the flow, I agree totally that, you know, with Dr. Hasan and Dr. Ramzi, that there is some debate between doing complete vitrectomy or just cool vitrectomy endophthalmitis, and don't do a lot of manipulation to avoid any tear or hole in the peripheral retina. So I believe the best way to do that, if you can decide intraoperatively. As you say, it's not, endophthalmitis cases are not the same. You have some cases that's mild, I mean, no traction, no adhesion, but sometimes also you have very difficult cases. So in those cases, if you deep digging and trying to remove all the membrane, you might end up with something. But the best thing is to do, if you can, is to do, you remove vitrectomy as much as you can, because the more you remove the vitreous cavity, the more you remove the endotoxins and bacteria, which is the most toxic effect on the retina. So I think we shouldn't stick to one certain technique. It depends on the case. If the case is going easy, like if endophthalmitis fungal, like Dr. Ramzi show, it's okay. Some people, for example, decide to do or insist to doing BVD, for example, in some cases, which is it could be very dangerous in those cases. But sometimes you can peel it easily. So you put in our mind that we remove as much as vitreous as we can, if allows us, the situation allows us. If not, just do a vitrectomy and do injection antibiotics or whatever, and then definitely it will be best result if you complete vitrectomy. That's my my comment.
Thank you, Ahmed. Any other comments? Fast comments?
I totally agree. And one really important point Dr. Ramzi mentioned in his video, maybe people will kind of not notice, but the fluid air exchange is very important that Dr. Ramsey did, and I do that multiple occasions, 4 or 5 times as much as possible, because that really helps clean all the vitreous, all the all around the ciliary body. So that's just one point I wanted to point out.
Thank you, Hasan. Any comment, Amjad or Dr. Iman? Anyone want to comment, please?
I think they said it all.
Okay, so we have a few questions we want to answer that before we move to my dear friend Hasan. But we need a very fast answer, as short as possible. Also, this is what about use of steroid concomitantly with antibiotics? This is Amjad for you when you are doing,
I only give steroids topically, not intravitreal steroids, Mohammed. I give topical steroids after surgery, or also after injection, start steroids, but not intravitreal.
Yeah, because Dr. Ramsey, before we are used to do when we are giving as management of endophthalmitis, we are giving 3 antibiotics, then we are giving also a steroid dexamethasone before this era.
Yeah.
Now I don't think this anymore is applicable, right?
Right.
Yeah, I personally use both Vanc, ceftazidime, and Decadron, dexamethasone injection. And
you are still using that, still you are using Hasan the dexamethasone?
Yes,
yeah. I mean intravitreal, you are injected.
Yes, I inject 3 things, and
so because this is also a debate. Some people, they are not anywhere giving. Some people.
I think it's very debatable, and I used to, like Dr. Hasan, do the intravitreal injections of steroids. But with the newer topical steroids, especially with the use of Derzol, I've found it to be quite effective, and I don't have to worry about making things worse with a steroid injection. But again, that's all theory. It's all debatable. And I have no problem with doing the injections the way Dr. Hasan does.
Yeah, I mean, Duracell is probably just as strong as the intravitreal.
Yeah.
Unfortunately, we don't have that,
if I see that there's really a severe fibrin reaction that we need some anti-inflammatory treatment, I prefer to do subtenon steroids instead of intravitreal, Hasan, together with topical steroids. But so this is my experience. Maybe you can be right, but intravitreal steroids did not make sense in my cases, and I tried that. But so as you say, this is very debatable topics.
Okay, there is a question from my dear friend, Dr. He's a VR vitreoretinal, well-known vitreoretinal surgeon in Sudan, Dr. Babakar. His question is, new way we can do a vitreal tab using 23-gauge trokers? And his second question, would injection increase chance to introduce, no, this is another question from a different person. Okay, any comment about this one?
Go ahead, Dr. Ramsey.
Yeah, Dr. Ramsey.
So actually, if possible, I would try to take vitreal samples with a 27-gauge trocar. This is much safer comparing the aspiration. So, but it's not possible all the times. The busy day operating room is not available, and if possible, I prefer to use a 27-gauge trocar, because insertion of trocar is pain for the patient, but then there's no pain. You can get directly vitreous cavity, and you can take vitreous as much as possible, and this is also much safer about the retinal detachment and tractions, but it's not always possible, as Dr. Hamad also mentioned, that the same things. Yeah.
Okay, Dr. Ramsey and Amjad or Hasan or Ahmed, 25, when you are doing this one, you are doing at the same time a vitrectomy, or you are only doing but just to take the tab and go off?
So if I do not plan to do vitrectomy, I just do tap and give injections and stop. But if they plan to do vitrectomy, I can continue, but not all the times.
Then another question, would injection increase chance to introduce microbes posteriorly?
So
yeah, Hasan, go on. Dr. Hamad.
Yeah, Amjad, please go, Amjad. Please go ahead, Amjad.
So if you're doing it, this is a patient that already has an infection, so I wouldn't be worried about causing an infection, and we're injecting antibiotics into the eye. So, I mean, if you're injecting an actual antimicrobial agent, the chances of introducing additional microbes is extremely small. And again, when I do a tap and inject, I do the typical pre-injection protocol where I use the betadine, I use the speculum, I make sure everything is nice, as sterile as possible and environment, and you do what you do with a regular injection. And so there's always a possibility of, but in a patient that already has an infection, I wouldn't worry about it.
I mean,
Okay,
the risk and benefit is just much higher benefit over the risk. So you have to go with that.
Yeah.
Okay, so we are running behind the time also. I need a very fast and only in few seconds answer this question. When exactly you start steroid? I mean, immediately after diagnosis of endophthalmitis or 24 hours after initiation of antibiotic?
So we do topical drops, and at the time of diagnosis, you do a tap, inject, and send them home with a topical steroid.
Excellent. Now it's my time to.
Yeah.
So Hasan, you are ready now to.
Yeah.
Dr. Hasan is my dear friend. Also, Hasan Bahrani is an MD, retinal specialist, a medical director of American Eye and Retina Center, Erbil, Iraq. Hasan, my pleasure to be with us. Thanks for coming, and please go ahead. Mike with you.
Okay, so thanks, Dr. Al-Omari, for the kind invitation. Thanks for the other speakers to share the podium. So I'm going to talk about cataract, posterior segment complication in cataract surgery. So my talk is going to be short, nice. Cataract surgery is, one of the most successful surgical procedure we perform. However, complications can be really, really devastating, not only for the patient, but also for the physicians. And complications can be taken care of if recognized early and taken care of immediately. So if somebody doesn't want complication, then they should stop doing surgery. We will all face complications, and therefore it's the way you manage the complication that matters. It's not that you have complications. So there are 5 major posterior segment complications of cataract surgery, and those are there are much more, but these are the 5 major ones. The retained lens fragment, we have post-operative endophthalmitis, which Dr. Hamad, Dr. Afshi has spoke about. We have retinal detachment, CME, and subluxated or dropped IOL. Today, I'm going to be talking only about the first, the retained or dropped lens fragments because of the time. So the retained lens fragment is in lay term dropped lens. It can be as high as 1% in people who would experience hands. However, it can be higher in residents and new graduates. The risk factors for retained lens fragment are mainly limited pupillary dilation, traumatic cataract, patient movement during surgery. So that's why good akinesia during surgery is very important. Not just good anesthesia, but also good akinesia. Also pseudo-exfoliation and Marfan syndrome. I think in our population in Iraq, we do see a lot of pseudo-exfoliation because of the exposure to the sun, the heat, and that is a very problematic thing for our population. Again, so what are the primary ocular effects when we give the retained lens fragment? So mainly we're talking about 2 major things, the inflammation and the intraocular pressure. So the degree of the inflammation and intraocular pressure is usually proportional to the size of the lens fragment. Typically a cortical remnant, it can be small, but it hydrates usually post-operative days. So the retina specialist will look into the eye and assess the size of the cortical remnant, and that's important to determine whether the surgeon will go into observation or do vitrectomy. As far as the retained nuclear material, usually it's associated with higher degree of inflammation and higher IOP. And usually the reason for the higher IOP is because of the liberated lens proteins and macrophages disrupting the trabecular meshwork. So if you don't treat it appropriately, then those would most likely go to peripheral anterior synechiae and chronic angle closure glaucoma. So what if you get a retained lens fragment intraoperatively? What to do? I mean, the most important thing is you should not attempt to retrieve the lens fragment from the vitreous cavity. That's definitely a no. And kind of you're kind of apprehensive intraoperatively, and you want to go get it, and you're worried about speaking to the patient postoperatively, and that's, you know, you should just tell yourself, no, I mean, don't do it. So these maybe aggressive maneuvers can lead to vitreous traction and also getting a horseshoe tear and ending up in a retinal detachment. So instead of fixing the problem, you're actually making it worse. You're digging up a hole for yourself. And again, also a limited anterior vitrectomy should be done, and removal of the cortical material in the anterior segment also should be performed. Make sure to kind of sweep the anterior chamber for any remnant of the vitreous or vitreous wicks, as we may say it, that may go to the anterior chamber and to the paracentesis incisions. And therefore, it's really important to use maybe anterior chamber Kennicort or triamcinolone to delineate the vitreous strands. Again, this is a very important point. The third one is you have to really put an IOL only if you are absolutely sure there's a good sulcus. So in the past, in the US, a lot of people still use ACIOL, but I really tend not to want to use ACIOL, and I recently never use ACIOL. So sulcus IOL can be implanted if you're really sure, and there's a good sulcus without compromise of the sulcus. Then go ahead and put a 3-piece IOL. Don't put a 1-piece IOL, because that would cause future iris pigments shaving, cause you uveitis and issues like that, UVH syndrome. So I'm really into leaving the patient aphakic because that kind of makes the retina specialist's job much easier. I know it's really tough to tell the patient you didn't implant an IOL intraoperative, but I think that makes the final outcome better and easier and complicates the case less for the retina specialist. A silicone-based IOL should be avoided because of the potential problem when we operate as retina specialists, because it causes very dense fogging during fluid air exchange. Again, and I cannot stress that enough, corneal incision. I know you're kind of scared and you got a retained lens fragment, a drop lens, and you just want to get out of the operation room and go to your next case maybe. But please do take care of the corneal incision. Make sure your paracentesis incision, your keratome incision are very watertight, because the last thing you want is to have, on top of what you already have, you have an endophthalmitis. And I've seen a lot of cases where, I see patient drop lens and then endophthalmitis, and as soon as I haven't even put the trocars, and I see leakage from the anterior chamber. So that's a very important point. So post-operative management, frequent topical steroids, usually every hour, cycloplegia, IOP lowering medications, full IOP management. I put them on even acetazolamide Domox. Even if the pressure is in the teens and 20s, I usually put them on all IOP lowering medications. And I found that to be helpful, not only to prevent the spike of IOP, but also to facilitate corneal edema. Also, I ask the anterior segment specialist to put the patient on Natrosalt drops and an ointment to help speed the recovery of the cornea. And of course, prompt referral to a vitreoretinal surgeon. That is really highly recommended, because I know some docs do kind of try to say, oh, I just dropped the cortical material. Maybe it's not that important. I think it will resolve. But I think it's really good practice to prompt refer these cases. As far as observation versus vitrectomy, most cases do require, from my experience, require vitrectomy for these cases, but only in few cases where you have minimal cortical material and controlled inflammation and IOP, maybe you could consider observation. when you have high IOP or inflammation, then you should go ahead for vitrectomy and lensectomy. In almost all cases of retained nuclear material, you should go ahead and for vitrectomy and lensectomy, and kind of try to assess intraoperative what dropped, you know, because I always speak to an anterior segment. Oh, I just dropped a very minimal piece of cortical, and then when I go intraoperatively, I find the whole nucleus or the whole lens. So that kind of helps me prior to vitrectomy surgeries to kind of have a plan, whether I'm going to use the vitrectomy alone, whether I'm going to do a cut down incision and do a sclerotomy and use a fragmentome, 20 gauge fragmentome. So that's kind of helpful. If you have a whole crystalline lens dropped, then those do not require immediate treatment, and because the capsule is intact, and you will not have inflammatory response as the other dropped lens. So the timing of the surgery, usually there's little evidence in the literature that suggests that you should operate on the same day or is associated with a better outcome. So what I usually do, I put the patient on multiple medications and try to operate within the first 2 weeks, usually around 14 days or so. And that kind of gives me time to help the cornea clear and get the medications in. So in long-term complications, we have retinal detachment, and those detachment, if those occurs, and in my experience, they end up going to severe PVR. So you try to avoid having a retinal detachment intraoperatively or postoperatively. Also, progression of diabetes is common in these patients. So when I have patients who are diabetic and have retained lens fragment, I usually go ahead and do some light PRP intraoperatively. Prognosis is pretty good, and overall, most final visual acuity 20/40 or better achieved in 40% of patients. Those patients that did not improve over the 44% usually had a pre-existing ocular condition such as corneal edema, CME, and retinal detachment. So you can have a very good prognosis in cases if you manage it appropriately. I'm going to share with you a case where this patient had a dropped lens early on in the surgery. And what was the great thing about what this anterior segment surgeon did is he pretty much just closed and left it for the vitreoretinal surgeon. You see my cornea is clear. I can go ahead and implant an IOL, and this is debatable. This is my technique where I put the lens first. But usually it's really nice because that docs didn't try to intervene and dig themselves up. So in this case, is make sure to close the incision very well. And then here I'm doing lensectomy. I'm doing cortical removal. You see we have the whole lens dropped. I think that lens dropped during initial grooving of the lens. And here I'm removing the cortical material posteriorly. I have a well-centered sulcus IOL. And then I usually try to remove the vitreous first, and that's very, very important where you have to remove the vitreous before you attack that lens. So you go ahead and then do the lensectomy for the cortical material. And then lastly, you go for the nuclear. And thank God, luckily, this lens I was able to remove it, use a 20/25 gauge, and I didn't need to go to fragmentome. So I always do endo laser for any suspicious area. I shave, especially inferiorly, to remove any remnant cortical lens material there. And you usually can have a good result. And this patient didn't require tamponade because the retina was fine. And I did intracameral Vigamox here. And then the case was done. This patient did very well and achieved a visual acuity of 20/40. So the key points in retained lens fragment is to restrain on the part of the cataract surgeon to remove lens fragments from the vitreous cavity, aggressive treatment of inflammation and IOP, timely referral to vitreoretinal surgeons, and good visual outcome can be achieved if proper intraoperative, postoperative management. Thank you. So we're not going to go on to the endophthalmitis.
Thank you very much,
Thank you,
Hasan, for this excellent presentation. It's really, you take all us in different way, and you collect all information that we need to hear from you. I know it's done in a few days that I inform you. It's not what you prepared it very well.
thank you.
I think there is a questions from Dr. Ahmed Al-Baqi. I know he will comment about these cases exactly.
Why? No,
I
just
know you, Ahmed, because you are having a good experience. But my question to Hasan, before my dear Ahmed, if you want to ask, if you are a vitreoretinal surgeon and the drop nucleus happened with you, so are you going to do it at the same time, or you are going to keep it as usual, or so 1 week or 4 days, 3 days? It can happen with the vitreoretinal.
Yeah, it happens to me, and I go ahead and do it right away.
Okay. So what is the minimum time and maximum time that we need to do this surgery? It's according to the if it is drop a whole nucleus is completely, or if it is apart, it make a difference. There is one question also, if there is a very small lens fragment inside the vitreous and not on the macula itself, far away, are you going to keep it? Is there a possibility to keep it, not to do the surgery at all, not to remove it?
Not to remove the lens?
If there is a very small fragment in the eye of the lens, and it is there and away from the macula.
Well, as I mentioned, if it's a nuclear material, then then it's probably need to have a vitrectomy, especially with the minimal invasive, I would say, vitrectomy surgery. I think I wouldn't want to have that nucleus in my eye if that was me. So, I mean, you would end up with having some chronic uveitis, and I have many patients who end up with this kind of issues. And then from looking at the eye and looking at the posterior capsule, it's not an intact posterior capsule, and I knew there's some kind of dropped lens somewhere that was not mentioned.
So that means we have to do the surgery, whatever the size of the nucleus drop in the eye, wherever it is, right?
I think if it's a nuclear material, I would suggest operating.
Yeah, but sometimes how can you differentiate? It is easy sometimes not to differentiate if it is only a cortical or part of nucleus.
Well, that's what I said. The physician or the anterior segment specialist should give us some information as to what happened intraoperatively. That's number one. Sometimes examination in the clinic can provide some useful information as to whether to operate or not. And also, looking from the inflammation and from the IOP, that can give us a clue as to what happened or the amount of material that is actually in there. If you have a spike of IOP, if you have an angry looking eye, this tells you there's more than just a small piece of nucleus.
Okay, any other comment from dear colleagues? Ahmed, Amjad, Dr. Ramzi, Dr. Iman?
Hasan, this is great. So this is great talk, also your case. I just want to say something about your surgical technique. So you prefer to do intraocular lens before vitrectomy. So what do you aim? Why you did like this? Because not in all cases, but in some cases we have very hard nucleus, hard rock cataracts and dropped in the vitreous cavity. And in this patient, in my technique, I prefer to eat the hard rock cataract with the filling of the vitreous cavity completely with PFCL, and to take the float cataract behind the iris on the original position, then do standard anterior segment phaco. In hard rock cataract, I think this is the safest way and time-saving way to remove the hard rock cataract with standard phaco instead of phaco fragmentation, because in phaco fragmentation it takes a lot of time it's traumatized and increase inflammation. So in such patient, I think to do a vitrectomy, to remove the lens first, then make IOL implantation is better. So therefore, what was your aim? Why you prefer IOL implantation at the beginning of surgery? I really wonder what was the.
Yeah, I actually given us a talk about this. This is I have been doing this for many years actually, and that's my way to go technique, especially in most drop lenses, and especially also in traumatic cataract, where you have. I mean, in this case, the sulcus was very nice, but most of the time you don't have a good sulcus and you have some issues. But I found out that when you do this, it actually makes your IOL very stable. I mean, imagine you're doing phaco and you have an open posterior segment. It's really tough. And then you end up, you know, I mean, you're doing phaco and then the lens drop and then you have to go vitrectomy and then you have to go back up. So in my case, you really never had an issue. And I have usually easy going with the fragmentome in cases where there's hard lenses. But the main thing I found in my experience is that the stability of the lens when you place it before you remove the lens material is amazing. And I have usually, and then also think about you know, introducing phaco again, the cornea is already edematous, and then the endothelium already hydrated. So in this case, if you know, my corneal clarity remained the same during the entire procedure, because what I did, as soon as I put the lens, I divided the anterior segment from the posterior segment, and I don't have any corneal endothelium hydration. And in that way, I kind of say, you know, I could do, you know, an hour, 2 hour surgery, it's fine. But I used to do that technique where I introduce the phaco and then do the lensectomy in the iris plane. But I found the cornea to be hazy, and then I have to do vitrectomy. And in some cases, as you know, and all of us know, sometimes these patients have retinal detachment case along with the drop lenses because of the aggressive manipulation and stuff. And you won't really have sometimes success of the vitrectomy. It depends on the person, depends on the cornea clarity, because how much you can do inside the eye. So I think this is a good way to keep the IOL very much stable, to also keep your cornea clear. And I think if you have an issue with eating that with the small 25 gauge or 23 gauge, then a fragmentome should do. So, I mean.
Thank you, Hasan. I know that you have one presentation about these topics with us in Al-Qasim Family International Conference. So, but it will take a long time to explain. So we are not having any time, and you already take 22 minutes, not 10 minutes as you tell Dr. Ahmed Al-Bakri. So now it's my pleasure to introduce Dr. Iman Abdul Latif, MD, Uveitis consultant, lecturer of ophthalmology at Alexandria University, Egypt. Dr. Iman, please, you can share and start giving us your lectures.
Thank you very much, Dr. Muhammad.
Okay, if you can share your screen, please.
Thank you very much, Dr. Muhammad. A pleasure to be here with my colleagues and both the speakers and attendants, and always an honor to participate with you. We shall give a simplified approach to the etiology of cases of retinal vasculitis. This is part of the result or the conclusion of our Egyptian experience for the past decade or so. To reach the cause of vasculitis, we will specify the case according to 5 points. What we used to do years before is to refer these cases of vasculitis to the internist or dermatologist to look for a cause among dozens of causes, and usually he does not come up with the specific cause because of the very long list of possible causes. And you know, it's very difficult to find something you don't really know. So instead of saying for your kind care, for systemic workup and so on, let's see how the ophthalmologist can really reach the cause and treat it quite perfectly. You specify the case according to 5 points. Number 1 is the type of vessel affected. Certain diseases tend to affect the arteries, others tend to affect the veins, and a third group affects both the arteries and the veins. The whole approach depends on a solid concept in pathology known as tropism. Just as the green plant bends towards the light, bends towards water, bends towards the gravity, also each disease has a target that it is directed to reach. For example, when I get a prick with the hepatitis C virus, I do not get the disease in my finger. It goes to my liver because it has receptors that call for it. Likewise, every disease knows its target and its target calls for it. When you get a case of vasculitis in which the arteries are the main type of vessel affected, these are your VIPs. These are the top of the list causes, at least in Egypt: systemic lupus erythematosus, polyarthritis nodosa, syphilis, which is resurging, and herpes viridi, both the simplex and the zoster. On the other hand, if the veins are affected, sarcoidosis, Behçet's disease, and Burchot retinochoroidopathy. A third group of causes tends to affect both the arteries and the veins, and by arthritis and phlebitis we mean combined artery and vein inflammation in the same eye. Look for MS, toxoplasmosis, and Wegener's granulomatosis. The second point in the clinical scheme is whether the vasculitis is occlusive or non-occlusive. And to understand this point, we need to know the difference between two separate pathologies. Vasculitis is a pathology of the wall of the vessel, whereas occlusion is a pathology of the lumen. So inflammation of the wall, vasculitis, could be associated with occlusion, and in other cases it may not be associated with occlusion. Occlusion, on the other hand, can occur in association with inflammation. So we have cases with inflammation of the wall plus occlusion of the lumen, which we call occlusive inflammation or inflammatory occlusion. And we have cases in which there is inflammation of the wall without occlusion of the lumen, which we call non-occlusive inflammation. And the third subgroup is what I need to focus on, is that we have occlusion of the lumen without inflammation of the wall. And this group is usually missed. You get a patient with a branch retinal vein occlusion without vasculitis, without wall inflammation, without uveitis, no cells, no reaction, no leak on fluorescein angiogram, nothing. So you get a pure occlusion. And what most people do is that they look for coagulopathies. They advise the patient to stop smoking, give some antiplatelets, and so on. And then 2 months later, the patient gets another branch retinal vein occlusion. And again, they examine the coagulation system and do some maybe laser, maybe injection for the macular edema, and so on. A couple of months later, the patient gets a stroke and dies. What could this be? This is a Behçet's disease. So let's not forget that a big category of uveitis diseases cause occlusion of the retinal vessel without a noticeable inflammation. So you examine the patient, you find no uveitis, you find pure occlusion. And these are really missed because we focus on the ocular problem as if we are treating an eye without a body, so to speak. The following diseases are most commonly occlusive. It is rare to find a patient with vasculitis without occlusion in these diseases. Behçet's disease, herpes viridi involvement, whether simplex or zoster, and toxoplasmosis. And I'd like to elaborate on toxoplasmosis in a few seconds. The classic presentation of toxoplasmosis we are all accustomed with is a posterior uveitis in which the patient has a scar and an active satellite and some vitreous infiltration in front of the lesions. This is but one of 12 well-known and documented ocular presentations of toxoplasmosis. Unfortunately, the other 11 presentations are usually missed because we are awaiting the classic presentation to show up. One of these commonly overlooked presentations is the toxoplasmosis-induced vasculitis. We shall now see a picture, a photo of it, and there is no scar, no satellite, no anything. On the other hand, some diseases are known to avoid or to cause vasculitis without occlusion. On top of the list comes sarcoidosis and multiple sclerosis. Again, one of the thinking paradigms we have to correct is the association of multiple sclerosis and the eye. We are very well aware of optic neuritis and multiple sclerosis. That's why many patients with multiple sclerosis are missed and the diagnosis of MS is delayed because they do not present with optic neuritis. One of the signs of multiple sclerosis in the eye is vasculitis, which could occur in absence of optic neuritis or before optic neuritis. So let's not delay the diagnosis of this serious disease, just waiting for optic neuritis to draw our attention to look for it. The third point is the size of vessel affected. The retinal blood vessels are a tree which has a main trunk, big branches, and terminal arborizations. And every disease attacking the retinal vasculature tree tends to affect one segment in particular. There are diseases that attack the central retinal vein, for example, others that attack the branch retinal vein, for example, and so on. I would give one example for the sake of time. Sarcoidosis is a disease of the central retinal vein, and it is non-occlusive when it causes inflammation in the central retinal vein. And this is so unique and so diagnostic that it is written clearly in quite a number of the uveitis textbooks that when you find a case of non-occlusive inflammation of the central retinal vein, this is a case of sarcoidosis still proved otherwise. And there are hundreds of other rules which I don't have the time to go into tonight, but it would be enough for me to give you the main idea. The fourth point is the pattern of vessel involvement. Whether the involved vessel is involved in a diffuse manner or in a segmental or skip lesion manner. From the diagnostic point of view, it is of our interest or of our benefit that the case has a segmental involvement. Because in the literature today, till this moment, only 4 diseases have been mentioned to cause skip lesions. These are sarcoidosis, Crohn's disease, giant cell arthritis, and polyarthritis nodosa. So when you get a case with segmental vasculitis, your list of differential diagnosis is dramatically reduced. And then it becomes very easy to differentiate between them. For example, polyarthritis nodosa is a disease of the arteries. Sarcoidosis is a disease of the central retinal vein, and so on. So the list of segmental vasculitis are only these 4. The last point in the algorithm before we move to some clinical application in a few minutes, is whether or not this vasculitis is associated or not associated with vitreous infiltration. And this is another point we need to understand the truth underlying it. There was kind of an old concept that active vasculitis has a reactive vitreous or some cells and protein in the vitreous. And when the vitreous is clear, this denotes that the vasculitis is now quiescent. This is far from being true. Some cases of vasculitis are extremely active with a clear vitreous. Others, on the other hand, could be really quiescent and they need even tapering and withdrawal of the treatment, but the vitreous still bears a lot of cells. I shall now give you 3 examples on this scheme, and we will go through them quickly to see how far they are different from one another. This is a photo of a patient with multiple sclerosis related vasculitis. The points on your left-hand side are the 5 points of the clinical scheme we have just mentioned in order. So point number 1 is the type of vessel affected. Multiple sclerosis related vasculitis is a combined artery and vein inflammation. Number 2, it is non-occlusive. Number 3, it is peripheral. As we see, this is the terminal arborizations of the retinal vasculature tree. It is diffuse and it is associated with a vitreous infiltration, which makes the picture kind of hazy. Now, what about these yellow spots we see in the photo? These are not cotton spots or any markers of occlusion, but rather they are the snowballs of intermediate uveitis associated with multiple sclerosis. This is a classic textbook picture of sarcoidosis, and it is so educational and so impressive that I deliberately showed that it is taken from a book. Actually, I took it from Kensky. And the reason I insist on teaching on this photo is that it shows some signs that are really seen in real practice, unfortunately, because the cases are mostly treated empirically by several doctors before being referred to the uveologist or the uveitis specialist. With this photo alone, you can kind of swear that this is a case of sarcoidosis without any systemic investigations ever. The points on the left in order. Number 1, it is a case of phlebitis. This is the vein involved. So sarcoidosis is a disease of the retinal veins. Number 2, non-occlusive, because if this central retinal vein was occluded, you would find a flood of flame-shaped hemorrhages and cotton wool spots all over the fundus. Number 3, it is the central retinal vein, the main trunk, that received most of the attack. And number 4 is the skip lesions, as we see that some areas are clinically affected and there are intervening areas of clinically sound vessel wall. Number 5, vitreous reaction. And number 6 is the diagnostic feature of sarcoidosis known as candle wax drippings or toque de bougie. If I have a few moments, I would elaborate on this important sign. Where in this photo is the candle wax drippings, do you think? Previously, there was kind of a concept that the candle wax drippings are those whitish or yellowish exudate surrounding the vessel. No, this is not the candle wax drippings. These whitish or yellowish exudates surrounding the vessel are known as exudative vasculitis. The clinical scheme I'm speaking about today is a clinical description. There is another classification of vasculitis which I would not elaborate on today. One of its types is exudative. It is the type of vasculitis which gives out a lot of fluid outside the vessel wall. The water becomes resorbed and the lipid remains as this cuff of greasy substance surrounding the vessel wall. So this greasy substance surrounding the vessel wall is not the candle wax drippings. The candle wax drippings diagnostic for sarcoidosis is the uneven thickness of the perivascular cuff of exudate. So if you look at the perivascular whitish greasy substance, you would clearly see that it is very thick at some areas and quite thinner at other areas. This particular point is the candle wax drippings. And the reason that only sarcoidosis can do it is that the pathophysiology of sarcoidosis induced retinal vasculitis is inoculative. Sarcoidosis as a disease comes inside the retinal vessel wall and puts discrete granulometer, like the cocoon of the silk caterpillar. The granulometer are a dynamic structure, a dynamic creature, just like us. They are born, then they mature, then they heal or decline. When the granuloma is juvenile, just starting, it harms or destroys the vessel wall a little, and thus gives out a little exudate. Then the granuloma matures, becomes fully destructive and fully harmful. So the exudate is more around it. By time, whether or not the patient receives treatment, the granuloma will age, will senile, will decline. And so the thickness of the exudate around this part of the vessel wall is reduced again. There is only one piece of information left, which is that the granulometer put by sarcoidosis inside the retinal vessel wall are out of phase. So one granuloma is still juvenile and another is already mature and the third is healing and so on. So the candle wax drippings means that the perivascular cuff of exudate around the blood vessels is not equal in thickness, and this is only in sarcoidosis. And to convince you with this message, for example, TB, it's another granulomatous disease, and it can cause exudative vasculitis just as this, but it can never cause candle wax drippings. That is to say, the perivascular cuff of exudate in tuberculous uveitis is uniform, is even. This is because the pathophysiology of tuberculous retinal vasculitis is not inoculative. We have no granulometer. It is reactive. The tubercle protein, which is the most antigenic part, excites the immune system of the host, and then the immune system replies by the host cells themselves, causing a diffuse infiltration of the retinal vessel wall. So if you take a biopsy from the retinal vessel, in a case of tuberculous vasculitis, there is no granulometer, no bacilli, no anything.
Doctora, you are ready to finish? You are already exceeding the time.
Okay. I'm very fine, I can stop.
You can conclude, please.
Okay. I conclude, Dr. Mohammed, with another picture on the contrast of the previous one, which is a Behçet's disease, typical retinal vasculitis, no exudate, no even inflammation. You can just find a branch vein occluded. And if we miss that this case has an underlying systemic disease and just treat it locally, we are indeed endangering the patient's life. Thank you very much for the opportunity, and it has been a pleasure being with you.
Thank you very much, Doctora, for this well organized and prepare and make it easy for us, because as usual, you know, uveitis is all the times difficult, especially for those that are away from this field. But you make it as simple as possible and easy to follow rules that we can reach a diagnosis and then management.
Thank you very much.
We will have a question at the end. Now, my pleasure also to introduce my dear friend, Dr. Ahmed Al Barqi, MD FRCS ophthalmologist. He's a consultant vitreoretinal surgeon, Sheikh Khalifa Medical City, Abu Dhabi, UAE. Dr. Ahmed, please.
Thank you, Dr. Muhammad. It's a pleasure to be here with you and with our colleagues and our attendees. Just today, I'm going to go back a little bit to medical retina. I know it's challenging to talk about DME nowadays. I think most of us knows a lot about DME, but I try to.
Dr. Ahmed, it's all the times new. We are all the time.
No, I will try to touch it from different perspective and some clinical applications just to be more interesting. So I talked about the DME, the algorithm. First of all, we all know about the pathophysiology of DME, but I want to highlight here something very important that we're still missing some thing in the pathology of the DME. If you look at the literature or the textbook, you'll find the exact pathogenesis of DME is not yet well understood. But there is some theories and some evidence for that. For all sure that vascular permeability play a very important role in that, adding to this for sure inflammation, and ischemia also play a role. And on some patients, actually we've seen in clinical practice, it's not only one factor, maybe all the factors come together. And if you add on top of this, the general condition of the patient, which is uncontrolled diabetes, which is very common in our area, hypertension, nephropathy, and others. And I wanted to keep the word others in your mind because we're going to need it later on. So in all these factors, usually we see what we call different response pattern. That's why we see in the clinical practice that some patients respond well, some patients respond poor, and there is non-responder. So this is, I think, the reason behind the different response pattern among patients who are seeing our clinical practice. So going very quickly to the treatment option we have in our hands right now, for sure, we are laser photocoagulation, intravitreal pharmacotherapy, and vitrectomy. I will start with vitrectomy first. And just we know the indication for vitrectomy, I think in DME, it's vitreomacular traction to posterior hyaloid or orbital membrane. Refractory DME, I'm totally against this to do vitrectomy in DME without traction. I have many reasons we can discuss later on, but I mean the most important reason for me is there is no randomized control trial to prove that. But for sure, a patient like this or like that, I think he will not get any benefit from injection unless you release the traction by doing vitrectomy. Going to the laser, I think all agree now the laser photocoagulation, I think the limited only for the focal non-central of DME, because most of all the studies showed that the macular grid or macular laser now does not have any benefit compared to the intravitreal and injection. For example, a patient like that with 6/6 vision, non-central involved macular edema with a focal leakage, I think the only way to do that for laser, because I don't think that no one can inject 6/6 vision. Going for the standard of the treatment now, the gold standard of treatment is the intravitreal pharmacotherapy. Just before we go that, we need to look at what is the ideal treatment strategy when doing intravitreal pharmacotherapy. I think we have two main factors we could check for it. We should know the target for our treatment, and we should have some tools to achieve this target. I think all target is to maximize and maintain the visual gain, not only improving, but only maintaining this visual gain, because the process of DME, a disease is long-standing, it's lifelong. So we are not expecting to treat it in a very short time period. So what about the tools? The tools we should have keyword for our strategy. We should also follow the trends of the treatment nowadays, and definitely guidelines. And one more important thing is outcome predictability. How could we predict the outcome during the treatment? About the key word actually and the treatment strategy is early. When I said early, I mean early treatment for sure. You should start the treatment as early as you can. Don't wait for control of blood sugar or whatever that. You have to start the treatment early, and also early decision during the treatment journey. That's what I call it. So if you are having a non-responder or poor responder, you have to decide early what's the next step. Don't delay the treatment. Follow the trend and guidelines. What about the trends nowadays? I think we all know about the trends nowadays, it's the longer durability and to decrease the treatment burden. And this longer durability actually came from new generation drug coming in the market. I think you all know about the prolosumab and also abicipar will come soon. This is long-acting anti-VEGF. And also nowadays we are also modify our treatment protocol to less injection and to increase durability by treat and extend. What about the evidence? What about the guidelines? Definitely when you are going to treat your patient, you should have guidelines you have to follow. Guidelines, the source of guidelines actually, it's either two sources, either the randomized controlled trial and real-world deaths or real-world life. There is difference actually between both of them, and just to highlight the main difference. In RCT, we study the efficacy for the drug to be registered, or get FDA approval, but in real life, we study the effectiveness, not only the efficacy. Another big difference is the inclusion and exclusion criteria. In our real life, we don't have inclusion and exclusion criteria. You have to treat any patient who comes to your clinic despite the level of his blood sugar or whatever. So you have to treat. This is not the fact, this is not the case in RCT. Another also difference is the tightly controlled group, but here in real world data is a practical nature, which is more practical. Another important difference also, the fixed treatment. You cannot change your treatment pattern in the RCT, but in real life, you have variable treatment pattern. And the last important thing is the follow-up. Follow-up in RCT is designed, and you have to respect it. But in real-world data or real-world life, follow-up is actual practice. So if the patient missed the injection, you cannot stop treating him. But in RCT, if they miss the injection, he will get excluded from the trial. So in all means, we should actually integration of all level of evidence in our hands. It's important to provide the best care for our patients. What about anti-VEGF? For all knows about, I think all of us knows about anti-VEGF. I just to highlight only just small point. We have many data to prove the efficacy and the safety of this drug. The treatment regimen we have in our hand now, it's different. We have either fixed continuous dosing or individualized dosing approach. I think most of us now switch to the individualized dosing approach, most commonly the treat and extend, trying to decrease, as I told you, the trend now is to decrease the burden of the treatment. What about steroid? Steroid is a very effective drug also. We have intramitral triamcinolone. It's not FDA approved all night. We're not used in EUE now, but we have steroid implant like dexamethasone or phenytoin implant. It's very effective actually in improving DME, and we all know about side effect. What I want to highlight here, it's not to mix between the glaucoma and the increased IOP. What we have seen in practice is we have transient increased IOP. During my oldest career, I found only one case that developed need glaucoma surgery, but all other cases just can controlled by topical anti-glaucoma, especially cataract is there. This is just to show the difference between famous trial comparing the side effects. It's not the same. Not all the steroids are the same to know that. Another important point when I go to discuss with you is the prediction of the response, how to predict the response. We have different predictors. We can expect the response. I go through it quickly. The first two, the baseline visual acuity, the poorer, the better. I mean, the patient with baseline poor visual acuity are those expecting to get more vision. Also, baseline central thickness also have a great opportunity to gain more vein. I will go through this just to show you the baseline visual acuity. This is just to show you the evidence base for that. We have many trials that prove that. Also, protocol T subgroup analysis, we all are aware about that. Baseline CRT are the same, the thicker, the better. Just this is trial from Restore. But that's what I want to focus today, is the OCT, detailed examination, because OCT, we cannot deal with just a thickness map. We should go in depth and try to analyze the OCT to find some changes or some prediction or some biomarkers also. So first thing that the ellipsoid zone, the hyperreflective spots, and the presence of subfoveal fluids. Ellipsoid zone, for sure, if you have a patient like this one with damaged ellipsoid zone, I think this patient was not expected to gain vision. So if the dry macula like this and visual acuity is not improving, I think there is no way to inject more compared to just normal or healthy ellipsoid zone. Another important point, I think most of us now aware about this, but just to refresh our memory about that and to know, to look exactly, are you looking to this during the practice or not? The hyperreflective spots or foci. We already see these dots or foci during the normal OCT. Before we usually overlook this and we treat it normal, but there are many trials actually show that this hyperreflective spots or these hyperreflective spots could be a sign of inflammation. They could correspond to aggregates of microglia activated cells. So in this case, should we consider steroid early? Just put this in our back mind during the treatment? We'll see. Many trials to prove that. And another point which is very important is the presence of subretinal fluid. There is another nice study actually shown that in 2017, they look at this biomarker, trying to find imaging retinal inflammatory biomarkers after intravitreal steroid. They look at this and they found that the presence of a subretinal fluid or subfoveal fluid could be an indicator of retinal inflammation. And did study dexamethasone implant versus Lucentis, and they found that almost 85% of dexamethasone treated eyes respond or dried well compared to the Lucentis or ranibizumab. And this is the study, showed that result. So they conclude that the presence of subretinal or subfoveal neurocenter detachment, in addition to the hyperrefractive spots, could be a sign of inflammation. Another more recent study, also 2017, also having the same finding about the subretinal fluid or submacular fluid. Another important point, which is now practicing now in my practice, it is the to study the or to look at the response after 3 monthly injection of anti-VEGF. Look at the post-hoc analysis of protocol I. They classify the response after 3 monthly injection based on the central macular thickness and the visual acuity gain. So if they found that they classify the improvement or the decrease in the central macular thickness by more than 20%, those patients as good responder and expected to maintain the same gain at 3 years. The same also for visual acuity, baseline visual acuity compared after 3 monthly injection. Those who gain more than 10 letters are good responder, less than 5 letters are poor responder, and something in between. And they found that those who gain 10 letters after 3 monthly injection are more expected to continue or maintain the gain at 3 years old, and 3 years follow-up, sorry. Look at here, they found that 50% of those patients who didn't achieve 10 letters, less than 10 letters after 3 monthly injection, they didn't improve a lot at 3 years. There are some patients improved, but the majority of patients does not improve. So I think this should, in our real practice, should be reflected in our real practice. So now if we have patient who didn't respond well after 3 monthly injection, what is the next step? Switch to another anti-VEGF or stay for the same or switch to steroid? Going about the first option, which is switch to another anti-VEGF. Personally, I was doing this before, switch among anti-VEGF in DME, but I stopped now. And when I look at the literature trying to find evidence based for that, I cannot. And I find a very nice article, review article, talking about this, the same issue, switching anti-VEGF in the treatment of diabetic macular edema. What they found, they look at 14 studies, trying to find the data or proof, and they finalize that it's great variability in the visual acuity and visual acuity gain, and also they recommend to have a randomized control trial to prove that. So since then, I stopped switching anti-VEGF in DME. So the next point, to stay anti-VEGF, give more a chance, or switch to steroid early. And there is a nice trial actually at 2018, actually, the switch, actually the answer to this question. It's a very nice one. They compare the study, one arm, after 3 monthly injection, who didn't respond well, they switch one arm to dexamethasone implant and continue with the same anti-VEGF for the same. And you can see here how big the difference in visual acuity gain. Those who switch early to dexamethasone implant or steroid, they gain a lot of vision compared to those who continue with the same anti-VEGF. So let's go now the algorithm, my algorithm of treatment of DME patients. So if I have a DME patient, I classify it into either it is a focal non-center involving DME or center involving DME. If it is focal non-center involving DME, I look at the visual acuity. If the visual at 20/20, I go for focal laser. If less than 20/20, I can go for anti-VEGF. And we have now protocol V from DRCRnet. What about center involving DME? Look at the look at the patient, individualized, what we call it individualized treatment, patient per patient. If it is victimatized eye, or there is OCT inflammatory biomarkers like we discussed earlier, or there is hard exudates, or recent stroke for the last 3 months, 1 to 3 months, or tractional element there, ARM or macular traction, or there is a cataract, the patient already cataractus and he's going to have cataract surgery. In victimized eye, I go directly as a first line for steroid if the patient is pseudophakic, because we have many trials prove that the pharmacoavailability of the drug of anti-VEGF in the vitrectomized eyes does not last longer compared to the implant. What about hard exits? I usually go for steroid, and I will share case with you about this later on. A recent stroke, definitely I go for steroid if it is 1 or 3 months. Tractional, definitely vitrectomy. Cataracts, I will go for steroid combination. If I go to combine cataract with injection, I'll combine the cataract for complication with steroid, because you know all that cataract surgery itself, it's induce what we call surgical trauma, induce inflammation. So by injecting a steroid together, I think we block both pathway, the Dme pathway and also the inflammatory factors that will release in the vitreous cavity post-cataract or post-surgical trauma. What about if you have OCT and inflammatory biomarkers? I look at the, if no, for sure I go for anti-VEGF as a first line of treatment. If yes, if the patient is pseudophakic, I'll go as a first line steroid now. If phakic patient, I'll try with anti-VEGF for 3 months and look at the result. If the improvement more than 20%, for sure I will continue in the same one. And if not, poor responder, I might switch to steroid. Also, you can also have here the option, if pseudophakic, you can also start with anti-VEGF for 3 months. But if you have a patient who has this inflammatory biomarkers in the OCT and does not respond well, I think there is no rationale now to continue on the same anti-VEGF. I prefer, as I mentioned, the early word is the key word. So you switch early, you get a better result. Also, I want to add one slide here, or one option if the patient is pregnancy. This one of my colleagues, Dr. Muhammad Abdul Nabi, he also alerted me to this. You have to add pregnancy, because if the patient is pregnant, I think we go for first line for steroid if possible, or laser if not possible. So this is for the current situation now. What's new now coming on the drug? What's the new treatment for DME is in the pipeline. The new concept, you know, the future of the DME are trying to tackle or target other pathways. And now I want you to remember the word others in the first slide. Now the drug, what we are doing now, we have something called extracellular pathway and the cellular pathway. The extracellular pathway, what we are doing now, it's just targeting the VEGF, overexpressed VEGF and inflammatory mediators. But the new coming, or the new thoughts now, is to target different pathway, cellular pathway at the cellular level, like angiotensin 2, integrin pathway, and Tie2 activation. This is the new drug coming in the market. So this is, if you look at this is the chart, which we are still here now. What we are doing now is just trying to target the overexpressed VEGF and inflammation. But what we are thinking now, or what is new is coming, is targeting the cellular level. Many pathway there still under investigation. So that is the new coming now. Combination of anti-VEGF dual pathway or other pathway that I told you. Also, they have some extended release platform, subcutaneous drug delivery, oral and topical even. It's still all this under trial. This is show us the pathogenesis of DME is still not understood. This is prove the fact. So this is just the new drugs coming in the market soon, the prorosumab and the abicipar. Also, there is another dual, you call it faricimab. It's a dual action targeting anti-angiotensin 2 in addition to the anti-VEGF. This is the Boulevard study. I'll not go through it for the sake of time. Integrin pathway, there is also some integrin receptor have a role in the pathogenesis of the virus eye disease. And they are investigating now a drug called RCG. We're waiting for the result, and the result, the study is called Delmar, phase 2 now. What about systemic, subcutaneous drug? We have something called Tie2 activation. If you remember from physiology, Tie2 activation is a key regulatory for vascular stability. And they found in diabetes, this Tie2 activation is downgraded by a certain enzyme called VEPTP. So they are trying now to study a drug that can block this enzyme. So it's called subcutaneous, given subcutaneous. The drug has a name under trial, it's AKB9778. So they are trying to study the efficacy of this subcutaneous injection to activate this Tie2 activation to restore the integrity of the blood vessels. So The time to, there's a trial now going on. I'm just show you how going on. Also, they are trying now an oral treatment called oral doses. This inhibits connexin 43 protein to prevent opening of the channel. They are also under investigation. Comparing that. The last one is topical drops. They are trying to use a topical 1.5% dexamethasone, and they are trying to study or innovate what we called SNB, the soluble ocular super nanoparticle technology, which can increase the concentration of the drug inside the eye. It's a specific vehicle to increase the concentration of that eye. So even topical drops, they are being tried. And this is the trial going on. Extended release platform, it is a new coming in the market now. They are trying to do a new implant. For all know about this port delivery system, BDS, I think it's available now in the, about to be available. It's only for AMD for sure. It's not yet for diabetic, but I think once it's approved for NMD, it will be applied for the diabetic. This is the cases of the these BDS. It's called ladder trial. It's phase 3 now, not phase 2. Just to be fast, so after all of this, what we discussed with you, we need to some facts. I will repeat myself in this slide. The last time I mentioned the same, that we are not curing the disease. The disease is diabetes, was incurable. We are just treating the DME. So we have to accept this fact. Another fact, as I mentioned, we are still something missing in the pathogenesis of the disease. One more thing, and the last thing, that one size does not fit all. We cannot treat the DME with a single treatment or single drug or single protocol. We have to use all our weapon, especially the new coming drugs to help us. So to conclude, before sharing with you very fast 2 cases, what we know now that DME pathology or pathogenesis is still not under many factor there. Anti-VEGF for sure commonly used, but has a burden on the healthcare system. And we don't want to reach the chronic DME because it's lead to irreversible visual loss. And again, here I recall the word early. So do not wait until the edema become chronic. What we need in our practice, efficient treatment, identify predictor outcome, also early identification of the response for anti-VEGF, and early decision which way to start, which switch early at the early stage. If we merge both, what we need, what we want, so we can reach our right target is to treat the right, to get the right treatment for the right patient at the right time. Just 2 quick cases to share with you from clinical practice. With this one, the first one with the case diabetic with hyperreflective spots, you can see here bilateral severe edema, and you can see here the hyperreflective dots there. So I start in this patient with intravitreal ranibizumab. After 3 monthly injection, didn't respond at all, no improvement in both eyes. So I switched to aflibercept. At that time, I was still switching, but now I stopped that because this is one of the reasons, because I didn't find any response. After 3 consecutive monthly injection, the same, exactly the same, copy paste, especially changing the reflectivity of the fluid, but in terms of thickness and visual gain, it was the same. So this patient received 6 monthly injection of 2 different anti-VEGF. So I think we all agree that the only solution now is to switch to dexamethasone implant. I switched it really, and after 3 months later, you can see the visual acuity improved, and look at the OCT to complete dryness. But again, if you look at the ellipsoid zone, is disturbed. That's why the vision does not improve well. And here the question came: if I use in this patient steroid early, will be the result different? I mean, the final visual outcome result, because I delayed him for 6 months. This is the other eye, the same. Another patient with hard exudate. It's very important to share with you this case, because I discovered in the patient who has hard exudate, like this patient. For example, this patient received 4 monthly injection of ranibizumab, and the last injection was done 5 weeks ago. And if it came to me, if you examination 2400, and you can see how much the extensive hard exudate around the macula and the fovea. So the plan for this patient was easy to me. I would check, I will definitely try with dexamethasone implant. And 1 month later, the vision improved. And look at the OCT. What I want to highlight here, the resolution of the hard exudate and the edema subside down. And look at here, just it's for sure we have some blake on the fovea, but it would not go away. but look at the pre and post. This is pre and this is post injection. You can see how fast the resolution, also the density of the hard exudate at the fovea was resolved. If you look at the evidence for that, we all know about Beaver-Dix trial. They found that the dexamethasone implant has a much higher incidence of greater regression of hard exudate and dilution of that. And also there is another trial, ongoing trial, study the effect of dexamethasone implant on hard exudate of diabetic macular edema. So I believe that using dexamethasone implant or steroid in patient with hard exudate at early phase, I think it will prevent to accumulation of this hard exudate at the fovea and lead us to permanent visual loss. I hope I stick to my time, and thank you very much for your attendance. And I hope I succeed.
Thank you, Ahmed. It's an excellent, as usual, as I told you.
Okay, just stop sharing now. Okay.
One by one. I cannot leave my eyes away from your talks. It's very
Thank you, my dear. Thank you.
Attractive. There is one question very fast because this one maybe we'll lose. Can you go to your second case? He is asking what are those lesions out of macula?
Which one? Second case?
Yeah, I think in the second case. This is my...
The hard exudate. Yeah.
Only hard
share again.
Hard exudate.
Yeah, it's hard exudate, just hard exudate. If you look at this one, let me check here. If you asked about this, all this...
No, he's saying the first. He is saying the first.
First case.
PRP, yeah. PRP laser.
PRP laser. Let's go back.
Yeah.
Okay. Yeah, these lives, yes. Yeah. This patient actually has a full PRP. If you can, this
too close, PRP. A little bit too close. Yeah.
Yeah, it's a very old technique, big laser scar. So that's it.
Okay. If there is any question to Dr. Ahmed from any panelist here, please. Dr. Ramzi, Dr. Amjad, Dr. Hasan, Dr. Iman, anyone want to ask Dr. Ahmed? Especially about the algorithm he have done. This one is an excellent, I think.
I think it's very good.
Just a very nice summary. I'm sorry, Dr. Hasan. I was just going to ask, have you any experience, Dr. Ahmed, with micropulse laser for DME, for simple DME?
No, yes. I agree with you. This is the only way we are waiting, I think, actually, for randomized control trial to compare the micropulse macular grade, for example, versus anti-VEGF. But in my hand, I didn't try it. I'm treating, as I told you, if it is macular center involved macular edema, I go direct for anti-VEGF.
I think, Ahmed, this is another weapon we didn't hear touch it, but there is a lot of people that are doing this, and there is a good result. I think
I agree.
So there is one he is showing. Please, can you show us the table comparing the steroid?
Table?
Show, please, the table comparing the steroid. Comparing steroids.
Steroid. Yeah. Okay. Yeah, this is just to show. Okay, I have to share a screen again. Okay. Just
while you share, there is any other comment from any other colleagues here?
It's
well, I mean, I just think all this. I think most of us retina specialists are, with practice, are concluding that steroids have a much higher role than we previously thought. And I think a lot of people, I mean, as far as my practice goes, that I'm more inclined to use Ozurdex and implants and all that than previously.
This is a question for all of you. If anyone want to answer, don't you think that if we're shifting, as Ahmed switching, sorry, as Dr. Ahmed mentioned, can we do it after 3 injection, or we are still thinking about 6 injection? As you know, because whenever we delay the switch or the management, and that means it will lead to a chronic ischemic changes. So also the effect of the steroid, it will be also less, not as we expect whenever we are shifting as early. Is there any opinion about this one or any comment about this point from any of the speakers?
Yeah, I can tell you, if you look at the study I shown that shall we stay or shall we switch, I think this answered the question. If you switch early, you will find a better result if you can, rather than delay it for 6 months. And it happened in my case, that the one I show you, it's a real practice. and that's why it stopped me, as I told you, to switch among anti-VEGF in DME. I directly,
I
if
mean,
I want to
Ahmad,
switch.
are you going to switch after 3? I mean,
Yes,
the debate.
yes. Now, yes. Now, if the
Or
patient
you
is,
have to wait because there is maybe some of them there is a late effect. Are you
yes,
still
exactly. Yeah, I agree. The question is here, after 3 monthly injection, if you have very poor response, I believe that this patient not 100% VEGF permeability or VEGF trigger disease. So it could be some sort of inflammation there, and we all know about that. So I believe if I switch early, I have nothing to lose, rather than I'm talking about, again, if the response is not well, I mean less than 20%, let's say 5 or 10%. So that's why. But if there is something in between, I can still keep the injection. Yeah.
Ahmed.
Yes, yes.
What about the young patient with phakic patient and with resistant to anti-VEGF? Do you switch the steroids directly or try the other anti-VEGF? And as you know, at least in my experience, I observed that aflibercept is more effective than bevacizumab. In some patients, it is not a response to ranibizumab or bevacizumab. And when I switch to aflibercept, I can take a good results. So what's your indication? What's your behavior in young phakic patient? This is
in young, yes. I have one patient like this. Yeah, I will. As again, in our practice is different than to switch to another anti-VEGF. You might find it in your hand different. It depends on the patient from patient. But as I mentioned, there is no evidence for that if you switch among anti-VEGF. For this patient, he received 6 injection. Also, we switch because of as you mentioned, his young age, and he refused. When we discussed with him the steroid, the side effect, we might had some cataract, and you might some increase of IOP. He refused at the beginning, but so we switched to anti-VEGF, trying, but we know, and it does not work at all. And at the end of the day, we give him a steroid with this after discussion of the patient, and he improved. The macular edema improved, and he was lucky that we don't have any cataract in this patient. Despite he's 32 years old and diabetic, till now he don't have any cataract. It was, 6 months earlier, 6 months later. So I believe, it's, if you want to inject this kind of patient, you have to discuss or counseling the patient very well. Tell him all the about side effects you might have and what are the tools. But in my hands, I found no benefit from switching anti-VEGF among DME. Because you know what, Dr. Ramzi, the issue when you switch, if you switch after 3 monthly injection or after 6 months, when you switch between anti-VEGF, that's my question. If you, for example, if you switch after 6 monthly injection of ranibizumab, and now you decide to switch to aflibercept. So what is your treatment protocol? Do you calculate the previous injection, or it will be naive patient? You have to start another 5 injection according to Vivid and Vista. So this is a good point. So if you can also help me, if you can tell me, if you want to switch, what is your protocol from aflibercept or whatever? If you switch, after how many injection of ranibizumab you switch, and for how long you are going to use the new aflibercept? Do you consider it naive patient, or you count from the first injection of Lucentis or ranibizumab?
Let me answer this question first. In naive patient, in my practice, I usually start with aflibercept because I experienced that it's more effective. There is some difference about the effectiveness between ranibizumab, bevacizumab, and aflibercept. If patient come to me with several injections previously somewhere, I count this, and if it's resistant still, I can switch, but I do not switch after 3 injections. At least for 5 injections, I continue. If still, but sometimes 6, but between 3 to 6 injections, I continue. And if they're still resistant, I can switch the others. But if the patient received bevacizumab and ranibizumab before, I can switch to aflibercept. If the patient received aflibercept and I continue still resistant, then can go to steroids.
But Dr. Ramzi, how many injection after ranibizumab? How many will continue?
Not 3, but at least 4, 5, sometimes 6 injections. It depends. If it is definitely ineffective, there's resistant, I can decide to switch after 4 injections. But a 3 injection is sometimes, I think, we may make a mistake. So after 3 injections, some patients I observed that like 4 and 5 injection may respond, and therefore usually prefer to do more than 3, but rarely 6.
Okay, we have questions here. Any benefit of posterior subtenon triamcinolone instead of doing intravitreal injection of implant, Ahmed?
I have no experience. I never do this.
Any other have any experience of that?
I have. Before dexamethasone implant, before anti-VEGF era, we used to use triamcinolone intravitreal on subtenon also. But subtenon injection has little benefits comparing the intravitreal. Therefore, we made a study with limited case, and then stop at do not do subtenon. But if we would do steroids, I think it would better to do intravitreal injections. But as I agree with Dr. Ahmed about the side effect of ocular hypertension is glaucoma, usually DEXA implant is much safer comparing the triamcinolone intravitreal injection about the glaucoma complication. Yeah. We should prefer, if it's available, we should prefer DEXA implant instead of triamcinolone, I think.
We have one question or one of the dear different. Can we ask Dr. John to prepare Ahmed Jum'a? Then we will have Dr. Hasan comment. Ahmed Jum'a is with us. He is raising hand. He wants to ask. Can you open the microphone? Yes. Yes, Hasan, can you go ahead, please?
No, I was just saying a subtenon, I think the fact that it is closer to the anterior chamber, and sometimes most people have difficulty getting under the tenon all the way back, closer to the macula, they end up putting a subtenon close to the anterior segment. And that is a really risky for cataract and, secondary glaucoma. So, I mean, I see a lot of that. So I think intravitreal, actually, it's compartmentalized into the Ozurdex, let's say, capsule, and also away from the trabecular meshwork. Therefore, you have less risky for glaucoma and other complications.
Great.
Okay.
Also, we can observe sometimes necrosis on the conjunctiva if it's inject just anterior part of the eye, and the particles in triamcinolone may stay there for a long period of time. Also may cause some necrotic conjunctival changes in that area. That I have some cases that they inject and referred elsewhere, as may causes reactions and a white plaque there. So it's really important to do injection. If we do subtenon, real subtenon injection, go to behind the equators.
Okay, Dr. Ahmed Jum'a, if you are here with us, please unmute yourself so that you can participate with us or ask your questions.
Hi, everybody. I just ask, what is your management for those with long-term or chronic foveal lipid exudate? Thanks.
Macular, you mean? Oh, foveal exudate. Okay, you can stay with us, please, so you can have any question. Yes, Ahmed, if you want to comment.
I think if you reach a stage of found this thick blake under the fovea, I think there's nothing to be done. The only way is to prevent this from happening. If you have fovea threatening hard exudate, I think using a steroid in this case, it might help to prevent migration or extending this hard exudate or blake under the fovea, as we see from Bevordex trial. But if you have there is nothing. There is no surgical treatment, as I know, or there is no way to do that with anti-VEGF or steroid more, because it's already
it will not
there.
help Ahmed even. It will not decrease that even in the fovea.
We are talking about blake. When you reach the stage of blake, which is thick layer, it's very difficult to be resolved, honestly speaking. But for those other hard exudate with lipid exudation, some way it's little less thick, I think this can be resolved. Exactly the same case I show you. All this lipid disappeared except the blake under the fovea it stayed there, and this was the limiting the visual gain in this patient.
Any other experience with that from Dr. Ramzi? Amjad?
Dr. Ahmed, on the other hand, in patients with very severe macular edema with hard exudates, when we dry fluid with anti-VEGF4, with steroids especially, with fast drying of the macula, we can observe that the hard exudate can move to the center of the fovea and became a kind of plaque.
Yeah.
So
yes.
therefore, I think sometimes I really hesitate to use steroid and to dry the macula fastly and may cause a moving of the exudate plaque materials into the fovea, and the vision can get worse in these patients. And you know, years ago, we used to use surgical treatment of this patient, and I have some experience about, maybe I mentioned about 15 years ago, in patient with hard exudate accumulation. If the exudation is behind the retina, but it's not fibrous scar plaque developed yet before this development. If we go subretinal area to remove this hard exudate, we should, in this patient, we save some ambulatory visions. And therefore, I think still we think about to do surgical removal, because technology in vitreoretinal surgeries increase. Surgical removal in hard exudate and supraretinal hard exudate material before fibrous scar tissue develop can be really effective. It's still, this is my experience, and we published this study years ago. And but if the fibrous scar is developed, it's never works, and we do
sometimes,
not
Dr. Ramzi, sometimes on the OCT, if it is long-standing, you are not sure exactly. You cannot differentiate. You will not be sure this is fibrotic or plaque on the OCT. So, and I think some patient of this, for example, this patient, the visual acuity was 2100. And if you do a big surgery like this and the removal and detach the retina and go under and remove this plaque, we are not sure about the visual acuity post-operatively. So maybe you find it, you open it, and you find it's fibrosis. So you do the surgery for it. I think, I mean, it's not. We need a lot of have a lot of cases to try to differentiate pre-operatively, which is one is fibrotic and which is not, before going for high. I mean, this is aggressive surgery for sure.
So,
any other? Yeah, sorry, Victor. Go ahead,
yeah.
Dr. Ramzi.
Years ago, we tried this surgery several cases, but I do not perform this regularly. But especially, you're right. It's not possible to differentiate fibrous scar tissue or fresh hard exudate supraretinal OCT. But sometimes you can guess, you can imagine, because plaque is in submacular area is a kind of hard, thick, hyperreflective area on the fovea. Yeah. The other one can be mobile, sometimes on the subretinal, if there's some subretinal exudations. And therefore, in some selective patient, the patient has a good vision. I mean, good vision is like 120 or 0.1 vision, and there's a huge macular edema and subretinal exudation also, subretinal fluid also. In this patient, I really hesitate to do a steroid injection and to cause the moving of the exudate material into the fovea and to reduce the vision. And I have some experience with this patient. These are really controversial and challenging patients, and to decide what we will, how we can treat this patient.
Yeah, agreed.
Any other comments from dear friends here, colleague panelists? I think, dear, you get the answers. Dr. Okay, so we have maybe one last question. Can we combine early steroid and anti-VEGF instead of switch?
You mean on the same setting?
Not in the same setting, but I mean, you give one injection, two injection, then give steroid like this. This is the way of the meaning of.
Because okay. I've known some physician or some doctor presented or give a talk. He is giving
at the same
triamcinolone with Avastin in the same syringe. So it has been, I mean, I hope that this is a question, if you can inject in the same setting, because
it's
combination,
combined.
I mean, combination, if you injected 3 monthly injection for anti-VEGF and you switch, I don't call it combination, I call it switching. But if you inject 1 month of anti-VEGF and the next month inject steroid, it's somehow for me, it's not, it's like very early switching, let's say that, because it's not, I'm not aware about any studies or big trial that study that to switching.
So I can
I have here Amjad, yes, Amjad.
Dr.
comment
Amjad,
on
yes,
that.
please. Yeah, please.
I have a few patients of mine that we start off with an anti-VEGF like Dr. Ahmed does, and after 3 to 4 injections, there's no response. We give a steroid, long-acting steroid implant, and then they do well, and then they get a little bit of edema again, and you still know the steroid implant is working. I will give another anti-VEGF, and that often helps. So we have people that have a 6 month
combined. This is what we call combined.
Oh, it's like topping up. It's like top up, right? Top up with anti-VEGF on a patient who has already implant inside the eye.
Okay. So basically, somebody that's responded to steroid, but it's not 100%, or they responded and then they come back with a little bit of fluid, and you still have the implant, the steroid implant is working. I have no problem with giving them anti-VEGF at that moment.
Yeah, when I was practicing in the US, I used to do both combination, both anti-VEGF and triamcinolone the same time.
This time.
Okay, very good. So, okay, before we came to the last, this I think last question. I think this one will go back to the first presentation. I think this for Dr. Ramzi. If cannot tell it is fungal versus bacterial, is it okay to inject antibacterial and antifungal at the same time? So if you cannot differentiate, is it a bacterial or fungal, and there is an endophthalmitis, is it okay to give the same at the same time?
I think, yeah, maybe this is option, but if I would have such patient, I would prefer intravitreal antibiotic injection and systemic antifungal treatment.
You will not give antifungal intravitreal.
It can be, but I did not have any experience. I did not do this both antifungal and antibiotic injection intravitreal, but systemic treatment is also effective in fungal endophthalmitis, and therefore I would prefer systemic antifungal and intravitreal antibiotic, and see the progression if there's some improvement, or if not, maybe in the second step I would prefer antifungal injection, because fungal endophthalmitis is not acute, is not massive, it's so slowly progress, and still we have time, we can do injection the second time. But this is my just theoretical behavior, so I do not have experience like that.
So that means you can wait until the result, you get the result maybe, then after that you can decide.
Yeah.
Okay. Any other comments, Amjad? Yes.
Yes, I've had patients that are severely immunocompromised, and they're in the hospital and HIV positive or on chemotherapy, and they have an endogenous endophthalmitis. And sometimes in those cases, it's really hard to tell because no really good immune reaction to really differentiate fungal versus bacterial. So like Dr. Ramzi said, we always start in systemic antifungal, but I have also injected voriconazole and antibiotics just to cover it all, because sometimes it can be tough to differentiate in those cases.
I share the same experience as Dr. Hamad. When you get a bilateral endophthalmitis, I go ahead and I do also intravitreal amphotericin. So the clinical scenario gives you an idea if you should proceed with intravitreal amphotericin also. So the fact that the patient immunocompromised by bilateral, or some recent surgery like lithotripsy surgery, or some other intervention, some huge venous cannula, or things like that, then maybe you should consider fungal endophthalmitis and go ahead and inject amphotericin also.
Yes.
Okay, I think
do voriconazole, by the way. I've stopped using amphotericin.
I'm trying to finish.
Really?
One question more. I will finish with this one. How long does it take to get obvious improvement after starting antifungal systematically? This is, I think, for Dr. Ramzi.
Depends patient, but usually we need a few days, like 3 to 4 days, to see some improvement with systemic treatments. But intravitreal injection, we add if you do intravitreal injection, we see improvements like 24 or 48 hours after injection. Usually we can see improvement.
I don't want to move before I answer these questions. This is from my dear friend and dear classmate, Dr. Ismat. I think Amjad, you can, Ismat Arefij. So what is the recommended intravitreal antibiotic dose for infant and pediatric age group? She's in the YouTube, following us in the YouTube. Anyone having any experience or?
Hamad?
I don't have a lot of experience with the pediatric endophthalmitis because they're not typically getting intravitreal injections or cataract surgeries at a fast enough rate to get a lot of those cases. I've seen a few pediatric cases of oncology patients with chemotherapy with indigenous fungal infection, and we use the same dose when we inject them. I mean, it's basically the volume of the eye is what you're worried about because you have diffusion of the medicine into the eye. And I believe the eyeball volume, or after the age of 2 or 3 years, is very similar to the adult as far as the vitreous cavity. So you don't really have to moderate a whole lot with the doses you're using. And I have not seen cases of toxicity by using the regular adult doses in those kids that have had that are suspect to have indigenous endophthalmitis.
Any other?
I believe the only thing you should be modified in pediatric is the systemic dosing, because you need to consult the pediatric. He was the one to give you how much you can get per kg. But I think for intraocular or intravitreal, I don't think that the dose will affect, because you usually take a vitreous tab, even in terms of volume, not only concentration. You draw like 0.2 and you inject 0.2. It's a term of small globe or something. You are doing vitreous tab first. So I think for intravitreal injection, I think the dose not change for the.
I don't know, Ahmed, if I imagine about this one, whenever you are giving antivitreal, VEGF, you are having not the same dose. When we are giving anything inside the eye, we are changing the dose for pediatric. Why in case of antibiotic? Why in case of antibiotic we think there is no difference?
The pathology is different here. If you are talking about the ROP, for example, for anti-VEGF.
No, I'm talking about antibiotic. What is the difference?
Because we are not giving any kids or any even adult intravitreal antibiotic unless if he has endophthalmitis.
I mean,
other
even
reason.
If you are giving oral antibiotic, you are not giving the same as those as well.
Yes, but you know, the systemic absorption.
Makes sense that there should be another special dose for antibiotic for children.
Exactly, but my point is the systemic absorption of the drug. If you take it IV or oral, it's more, cautious. You have to be more cautious. But if you inject inside the eye, it's only limited to the ocular space, and you cannot know. You will never be able to know if this drug. If you make a study, if you want to make a study to check the safety of intravitreal antibiotic for kids, you will never be able to check the toxicity, because the toxicity could be from the bacteria or from the toxin, not from the drug itself. It's not the case like anti-VEGF, for example. But so that's my concept. But we don't have a study, I think, as much as I can. But for me, if I have kids, I will give the same dose for antibiotic intravitreally, but for sure I will consult the pediatric to give us the systemic antibiotic dosing.
Dr. Iman is still with us. Dr. Iman is here. Dr. Iman.
Yes, Dr. Muhammad. Yes, Dr. Muhammad.
Can you give us your opinion? You are also dealing with uveitis, and maybe if you can have a children of uveitis and you want, did you ever need to, or endophthalmitis, and did you ever need to give antibiotic inside the eye? Inject?
Actually, my experience with infectious endophthalmitis is not as wide as my colleagues' experience. I'm dealing mainly with the non-infectious uveitis, vasculitis, optic neuritis, and these things.
Okay, Hasan, if there is any comment from Hasan, please.
Yeah, I just want to say that I don't change the dose, intravitreal dose for kids. That's number one. Number two, very important point. There's some anterior segment specialist here, probably. Please, subconjunctival antibiotics is not the same as intravitreal antibiotics.
Yes.
So it doesn't work. You know, it doesn't work, and this is just really important because, and I hope and I wish that people don't try to resolve this problem with subconjunctival antibiotics because it doesn't work. That's just my last 2 cents.
Okay, I don't know. Still, there is a question. I don't know. Can I get this also question? I had a case of 1-year-old post-phaco endophthalmitis, which they inject intravitreal antibiotic, but the baby eye become physical, yeah, within 2 weeks. So my question, would you consider vitrectomy as a first treatment? This is the last question. I will not take any others. So if there is any comment.
Can you repeat that question again, Muhammad? I didn't get it. What was the question?
Can you, it is there, Ahmad, Amjad, can you open the question in question and answer? You will find it, the last one. Okay. I had a case of 1-year-old post-phaco endophthalmitis. You are reading?
Yes, I'm reading it. So,
Yeah.
so it's a one. Is it? I mean, this is somebody who had endophthalmitis 1 year after phaco.
Yeah.
The 1-year-old.
No, not 1 year old.
It's a
1
baby.
year old. No,
Okay.
1-year-old baby post-phaco endophthalmitis.
If it's 2 weeks out and the eye is already becoming icicle, so this is a really bad prognosis eye. I mean, obviously they've had some severe inflammation, and becoming icicle means that I would do an ultrasound check on the retina. There probably is a retinal detachment, and there's probably a membrane in there on the ciliary body. That's why it's becoming icicle. There's really no good answers here. I mean, you could consider vitrectomy, but as long as the parents and everybody else understands that this is probably going to be a heroic measure, and most likely you will not be able to save the eye. But it's 2 weeks, still 2 weeks out from the infection, so it's a possibility. But I would not raise their hopes up, especially with a young kid, that you'll be able to do anything. But obviously, because it is a young kid, I would offer that option, and I would see if they want to go with it, as long as they understand what the prognosis is.
I believe this patient.
Or Ahmad? Yes, Ahmad.
I think this baby, you know, 2 weeks is too long to wait after he inject and he get a vitreous tab, I believe, tab and inject, and then he wait for 2 weeks. I think vitrectomy should be done at early stage after we do the first tab and inject, and then for sure you have to admit this baby and you see him next day if you cannot find any improvement, because we cannot now follow the guidelines of EVS about BL or not BL. So you have to go for vitrectomy. What I want to highlight here, we should understand that we all know that endophthalmitis is a devastating complication. It's not only vision threatening, it's globe threatening. You might lose the globe by evisceration. So I think we should be more aggressive in treatments in terms of, for sure, evidence-based. But for this baby, I believe he gave injection of antibiotic and he didn't improve. Because if he responds to the antibiotic, we'll never reach this stage of being phthisis eye. The issue here, the patient the baby get antibiotic intravitreal, but he didn't respond. So he should do vitrectomy at early stage, next day of the injection. That's my opinion. In this situation now, if the patient is already phthisis or the eye is phthisis, this is the final stage of endophthalmitis. This is the stage we don't want to reach it from the beginning. So that's
actually,
my comment.
The one who's asking, Dr. Fatma, I think her name,
yeah,
she's saying that it came later on to her when already is in thesis eye.
You know, Muhammad, my concept about endophthalmitis, it's a dynamic event. We cannot classify it as severe or mild, moderate, severe. It should be classified as early and late, because in one day, in few hours, the dynamic change can be changed. Also, what I'm doing now, actually, I'm not relying on EVS at all. I'm just trying on the red reflex. If there is a red reflex, good reflex, I can go with vitreous tap. If no red reflex and the vision is hand motion or counting finger, I will go for vitrectomy. Because if you look, you know, I want to ask, this is my last comment about EVS. If you look at the study, if you go through the details of the study, if you look at the group who didn't do vitrectomy and look at the incidence of retinal detachment and phthisis, you know, it was almost double, more than double in the vitrectomy group, despite the fact there is no change in vision. But if you look at the complication, those who didn't do vitrectomy, they developed double percentage of phthisis and retinal detachment. So I think we should consider the EVS guidelines. And nowadays we have
other way around. Isn't it the other way around? And patients who do vitrectomy develop.
No, I have it. I will show, because you know there is one study called CV. There is one study.
I think, guys, this is a debate.
Maybe I can.
I think Dr. Ramzi was a comment.
Yeah.
Dr. Ramzi.
I think
actually, I agree, Dr. Ahmed, about the EVRS study. EVRS distinguished reasonable guidelines for the treatment of bacterial endophthalmitis about more than 20 years ago. But many things changed during these 20-25 years.
Yeah.
And the technology, vitrectomy technology, it's get much better, and we can do surgery much safer comparing the previous years. And therefore, and also there's increasing trend to do early vitrectomy in such patients. I agree with you. Yeah. What about the young, the babies, 1 year old baby? Again, I agree with you. I would, so for the babies, we do injection on the general anesthesia. And therefore, in that patient, I have no experience in 1 year old endophthalmitis, but I would prefer to do vitrectomy as early as possible, maybe just vitrectomy after the this endophthalmitis. Also, it's not possible, easy to give 0.2 milliliters injection into the small eye, and therefore we could do vitrectomy and like limited vitrectomy and give injections would be much reasonable comparing the injections. So agree with you again, Dr. Ahmed.
Yeah. I actually disagree, and I think tap and injection is the way to go. As the recent also retrospective from the European, I understand. I mean, we can do vitrectomy and core vitrectomy much easier, but the devastating complication can occur with vitrectomy, especially in friable retinas. And I don't know. I mean, sometimes.
No, I mean, look,
yeah. Sometimes you can deal with things that happen on its own versus you causing the retinal.
Hasan and Ahmed, I think we will make another small webinars for you again.
No, it's okay. We all agree that we have to try tab and inject, but the only issue, if no improvement, you have to go direct for vitrectomy. Don't wait.
Absolutely. No, I totally agree.
Yeah, that's the point.
I think we're all in agreement.
I think we already came to the last point and the last of this webinar. I would like to thank you all. It was very interesting. I was thinking this webinar, it will be exactly as the time I was deciding by 10, 15 maximum, but now already we are about 3 hours. I don't know, but it was very interesting because the speaker, they are eminent and the talks are very important. There is a good point they raised and debatable about it. Thanks for all of you for accepting our invitation, and we hope to see you, inshallah, in another webinar. Thanks, Dr. Ramzi, and Dr. Amjad, my dear friend, Dr. Hasan, Dr. Ahmad, and Dr. Iman. Thanks for the company, for sponsoring company Allergan for their support, and thanks for Marvision for managing this event. And good night. Bye-bye.
Thank you very much.
Good night.
Have a good day. Bye-bye.
See you soon.
Thank you.
Bye-bye.